Okay, I've stopped sharing.
Mm-hmm.
Can I share my screen again?
That will be okay.
Yeah. Okay. Can you see my slides?
Yes, we can see them.
This is not slideshow.
Mm-hmm. You can try to go to the slideshow and then we see if it can, it will allow you to move to the next slides. If it can't, I think we can improvise. You can leave the slides in this mode and then you can click on the little corner where the slides are showing when you're actually moving to the next slide, and it will, I think they will move. Now they are
moving. So this is the conceptual framework. Sorry for that. This is the conceptual framework that we have been using against the background of poor socioeconomic status there has been unavailability of ultrasound hardware, that is the machines, and also lack of skilled service providers. Because of this lack of skilled shortage of sonographers and not enough training platforms in the country, I think we only have schools that train in ultrasound here in Harare and in Bulawayo. Otherwise, nothing else. It is against this background that this pragmatic course had to be done so as to address the gap. Because we know that with ultrasound, you are able to diagnose simple things like multiple pregnancies, placenta abnormalities, ectopics, that high impact interventions to stop bleeding, PPH, obstetric labor, which ends up leading to poor maternal and perinatal outcomes. So against this background, Ministry of Health in partnership with USET, Fetal Medicine Foundation, took this objective to train frontline health workers, that is nurses and doctors, in basic obstetric ultrasound scan, specifically to impart participants and with basic knowledge on ultrasound physics and functions, to train participants in patient positioning, imaging orientation, fetal position, placenta localization, simple biometric measurements, and amniotic fluid assessment. So a 5-day course, competence-based training course was adopted, which included both theory and hands-on training. And it had both physical and virtual components, that is last year in 2021, 2022. It had both physical and virtual component. It was held here in Harare and Bulawayo. Lectures were given virtually. The same lectures were given virtually for both participants who were stationed in Harare and Bulawayo, and a post-course assessment was conducted by the facilitators on day 5, basically using a Likert scale in terms of the assessment. And in terms of, so there were 2 cohorts for this assessment that we did. The cohort that was trained under the Higher Life Foundation sponsorship, and a cohort that was trained under the FHI sponsorship. FHI mainly focuses in Manicaland, so they brought their health workers from Manicaland, nurses and doctors. So in terms of composition, you find that 80% for the Higher Life cohort were midwives and 20% were doctors. And in terms of the Manicaland cohort, 85% were midwives and 14% were doctors. And this graph basically shows the distribution of the health facilities that were covered and the number of health workers, health service providers that were trained. You can see the various provincial hospitals. So the Higher Life training was mainly focusing on the provincial and central hospitals, whereas the FHI training was mainly focusing on their Manicaland cohort. The Manicaland cohort was going as far as even the clinics, staff from the rural clinics, rural health centers, etc., etc. So so these are the findings from the training. You find that in terms of patient positioning, not much of a difference, apparently, actually, from the Manicaland cohort, which was composed of people from the clinics, rural health centers. 100% of them performed well in terms of patient positioning. That is, they acquired the skill, they acquired it very well, And for the other, you can see from the graph. In terms of image orientation, again, you can compare the graphical representation. Not much of a difference between performance for those central provincial hospitals as compared with the Manicaland cohort, which had nurses and doctors from clinics, rural health centers, etc., etc. In terms of fetal position in relation to the mother, again, you can see the performances of the two different cohorts from the performances of the two different cohorts from the different nations. In terms of fetal situs, you can see again the performances of the different cohorts here. Participants from the central provincial hospitals performed better in terms of acquiring of the skills as compared with those from the Manicaland cohort. This is just an image of a picture showing situs in abdominal view, showing the stomach, barbell, umbilical vein, and also the heart pointing to the left. In terms of knobology image optimization, you can see that, in terms of this variable, performance was quite, required some consolidation, although most participants acquired, but it required some consolidation. Not much acquired this skill very well. As I was analyzing the data again, unfortunately, I couldn't analyze the depth and focus competencies because there was incomplete data on the questionnaires that were used to capture the information of the participants for the assessments. In terms of fetal biometry, generally, you can see that the skill was acquired. If you look at the well-acquired and acquired graphical representation, yes, and a good portion also needed consolidation, both from the central hospitals and from the Manicaland cohort. This is just an image of a head circumference biparietal diameter plane taken with the machines that were being used. And yes, very, very important, like what I was saying, talking of simple solution, but with high impact interventions. During these trainings, we have also been able to pick even some conditions that would give the couple or parents opportunity to make decisions about the pregnancy being carried. This was a case of severe bilateral ventriculomegaly that was also captured, picked as part of these exercises. And in terms of the abdominal circumference plane, again, this was well acquired and acquired. You can see performance was quite well achievable to the satisfactory of the assessors for the abdominal circumference plane. That is for both cohorts. And again, for fetal femur length, yes, this was quite a challenge. You can see that there were low numbers that acquired this very well. Yes, a good number on the acquired for the two cohorts, but a sizable number acquired, but still needed some consolidation. In terms of placenta localization and distance from the cervix, this was not a very difficult skill for most of the participants to acquire. You can see from both cohorts, well acquired and acquired was quite good. But for the central hospital cohort, it had quite also a big number which needed consolidation on this variable. Then in terms of placental cord insertion, yes, again, this was, I think it was a challenge for the Manicaland cohort, but well acquired for the central hospital provincial cohort. Then in terms of amniotic fluid assessment, I think this was an easy variable for most of the participants from the both cohorts to acquire, although a sizable number also needed to consolidate this skill. Then fetal cardiac assessment seemed to be the easiest for both cohorts. You can see they were acquired and they acquired that it was acquired by both cohorts. Ladies and gentlemen, yes, we think and we feel that these trainings are very, very important. Like what I was saying now, we have about 255 health service providers who have been training, because it allows early pregnancy dating. It allows early pregnancy dating, and also it allows, which is very important in the follow-up and care of these pregnancies, and also issues to do with multiple pregnancy. If a woman is detected to have a multiple pregnancy early, then they can be referred to the next level of care so that they deliver and have optimum obstetric outcome, both maternal and perinatal outcome. These are just images that have been taken using these simple machines. Here showing a membrane separating two fetuses, and here showing a lambda sign. Again, and just to show this picture, although not it wasn't from a clinic or what, but just to show one of the benefits of this early detection of these problems. You find that this was a patient who was diagnosed to have gastroschisis just about 2-3 weeks ago, and this was detected antenatally and was confirmed at Harare Hospital by Dr. Werenga. And the aims of these trainings, the aims of capacitating health workers in these skills is that this can actually work to inform and prepare parents for the birth of an affected baby, allow delivery in a specialist center for immediate postnatal treatment, or to allow termination of pregnancy in cases where you have lethal anomalies detected. And so we feel these are very important things. And even with these important skills, I mean, trainings for the fellows who have been with this program for the past 1-2 years, you can see that, yes, Prof. Chauke was talking about the fetal cardiac function, but we have been able to do some of these things, the 4-chamber views. You can see fetal heart screening views being taken by simple machines without color Doppler, black and white, grayscale imaging. Here, the main part, the right ventricular outflow tract showing the main pulmonary artery bifurcation, the 3 vessel views from these machines. So, ladies and gentlemen, as I wind up, we think that these exercises allowed us to learn that timely referral of cases like multiple pregnancies, suspected morbidly adherent placentas, placenta previa, abnormalized at term, growth-restricted fetus, and detection of anomalies, which gives good pregnancy outcomes, better perinatal and maternal outcomes. And this is also an opportunity for early prediction, prevention, and leading causes of maternal and perinatal mortality. Things like preterm birth, preeclampsia, and early dating and of pregnancy. Viability assessment, location of pregnancies, and managing of obstetric complications like ectopic pregnancies. From our assessment, we found that fetal cardiac activity was the easiest of the parameters to be mastered by the participants. Female length, situs, and knobology, image optimization needed more time for the consolidation of the skills. Yes, some we have been asking, is a 1-week course adequate? My response and my comment to that would be, this is just the beginning, and this is just the entrance into learning about obstetric ultrasound. Just to show some of the continuous learning platforms that have been available, and which I understand from our mentor, Dr. Werenga, okay, will be now available even to those who want to join in the near future every week. We have been able to attend weekly Friday meetings where we learn, like this one was on fetal growth restriction, polyhydramnios, obstetric Doppler, all the cases like this. There has also been a 24-hour online WhatsApp platform so that participants that have been trained throughout the country, they are able to consult virtually on the WhatsApp platform. They can send their images, they can send videos, and people respond to them. So the 1 week training, yes, the time may look limited, but with these on continuous learning platforms, people are able to even upgrade themselves. And we, like last year in October, we also held a refresher course that covered a twins protocol, FGR protocol, and common fetal defects. So these are some of the images from the trainings that have been going on. One of the sonographers, Mr. Admire Zanga, teaching participants, and I think this is a familiar face, one of the obstetricians undergoing the training as well. So ladies and gentlemen, I want to thank you for allowing me to make this presentation, and I want to acknowledge the following. The fetal medicine teams, both at Salem Gabe and Barrengatwa, UNICEF for supporting UNICEF, FHI, and ILI for supporting through buying of the ultrasound equipments and also sponsoring the trainings of healthcare workers throughout the country. And last but not least, the women who have also been scanned as healthcare workers were trained. I thank you.
Thank you very much, Dr. Madembo, for a wonderful presentation. Great work indeed. That is happening small steps. I'm sure with better cooperation, coordination, and funding, the trainings can be consolidated and can be lengthened. Just one question, I think, from Dr. Murewari Nema, congratulatory and encouraging results. Dr. Madembo, do you have any plans to publish your success stories?
Yes, plans are underway to publish our success stories. We are not just attending to clients, we are also capturing data of all the clients that are being scanned. So it's not very difficult to publish when you have the information. So the data of most of the patients that are being scanned is being captured in specific software that make analysis of the data simple. Over to you.
Thank you very much. In the interest of time, I think we'll move on to our next presenter. For our participants, you will not be able to raise hands, so it is wise that you text your questions and any comments in the chat box, and then we'll read them out as we proceed. Our next presenter is Dr. Henson Dube, who is a specialist from Bulawayo. He studied through the fellowship from the colleges of medicine of South Africa. He practices in Bulawayo, both in the public and private sector. He's the current acting head of department of obstetrics and gynecology at Pilo Central Hospital. He has a special interest in fetal and maternal medicine and is pursuing a subspecialty qualification in fetal medicine. He is a member of quite a number of associations, including RCOG, an associate member, a member of the International Society of Ultrasound Scanning, Obstetrics and Gynecology, ZSOG, a member of the Society of Maternal Fetal Medicine, South African Society of Ultrasound in Obstetrics and Gynecology, and also Society of Obstetrics Medicine, South Africa. Quite a big resume. Dr. Henson, you can proceed. Thank you. Dr. Dube?
Hello?
Yes, you can proceed.
Can you hear me?
Yes,
thank
now
you,
loud and
thank
clear.
you very much. So today I'm going to take us through the management of a short and funnel cervix in Singleton Pregnancies, and I've subtitled my presentation. This is because of some of the observation sector, where we get referrals of patients coming to us for cervical cyclage, even though sometimes they may not have a clear indication for such a procedure, that we all of us know that it may not be benign in all of our cases. So I wanted to start with what Abraham Maslow said. He said, I suppose it is tempting if the only tool you have is a hammer to treat everything as if it were a nail. Then I went back to look at what did he mean by this. Basically, he meant that human beings may have an over-reliance of a particular tool simply because the tool is more immediately available, it is more familiar, and other options are not available. And as you would see throughout my talk, that cervical cyclage in our public sector may actually be the hammer of our times in managing pain, which may, in some instances, be not the ideal tool to apply in those instances. So I'm going to relate to these two cases that we managed. One was in the private sector, the other was in the public sector. Case one was in the public sector, where we received a 32-year-old, was para 1, with a 1 live birth, no previous miscarriage of preterm delivery. So she had come with a second trimester scan showing a funnel length of 22. She was 23 weeks and 3 days and was referred for cervical cyclage. On the extreme right is a second case that we managed in the private 2 with 1 previous first trimester to get pregnant. And on example, and this ultrasound scan that was referred with showed a funnel width of 38 millimeters with a closed functional cervix of around 18 millimeters. And she was 20 weeks, 2 days and was referred for cyclage. So you can see that you have 2 cases or 2 patients who have very different obstetric histories, very different findings on the ultrasound scan, but are being referred for possibly the same intervention. So here I just put some of the pictures are agreeable. These are transabdominal ultrasound scans that the case 1 it came with that are quite showing you that there is some cervical funneling and indeed some loss of a functional cervix. These are the 2 images for the second case, again transabdominal bladder, and also evidence of funneling and a shortening of the patient's cervix. We manage these cases seeing that they are presenting to us with a referral of cervical cyclage, but appearing more or less different in terms of their background histories. So one of the options was, should we put cyclage in both of them? Should you do a transvaginal ultrasonography and follow them up? What is the role of progesterone in these cases? Should we just reassure these patients? So in case 1, we were able to repeat a TVS at our hospital at Mpilo about 40 hours later. And we found that, yes, indeed, there was a funneling. The length was 25 millimeters and they closed a functional cervical length of 36 millimeters. Second case, however, she actually declined the TVS. So in case 1, we thought this patient didn't have an indication for the cervical cyclage, so we just canceled the patient for a conservative in 2 weeks. On the second case, we canceled the patient, and the only option she could accept was cervical cyclage, which we were able to place in the patient. So I thought maybe we should, and why we thought would manage this patient in the way we did. So all of us would appreciate that preterm birth is a major determinant of neonatal morbidity and mortality with quite severe, enormous economic and social costs. But however, that measuring the cervical length and funneling with ultrasound can help predict which patients will deliver preterm. And that the transabdominal assessment of the cervical length may be used as an initial evaluation, but for a proper risk assessment, really the tool of choice will be a transvaginal or a transperineal measurement. Why is it so? We all know that the transabdominal route is less accurate. There may be some fetal paths that may obscure visualization of the cervix, especially after 20 weeks. It's associated with a poor resolution. And we know that the full urinary bladder usually required for a TAU can elongate the cervix, and it may indeed mask the funnel. And you could see from our results there that when we did the TVS, actually the results were a bit more severe than what had been reported on the transabdominal scan that we received. So what are the guidelines that are in place, and how should we be measuring the cervix? The cervix should be measured along its longitudinal axis. It must occupy approximately 50 to 75% of the image, that there should be no excessive pressure on the probe as it artificially appears to be longer, and it may mask the funnel of the cervix. And it should really be given ample time for you to conditions for each stroke, for example, that you need to take about 3 to 5 minutes to complete the assessment, and that we need at least 3 measurements. And then we use the shortest measurement for counseling our patient. There is some age diagnosis that I could get from ISWOC, where it says that a finding of a short cervical length is mostly straight. So that if you are to find a curved cervix, it usually signifies a cervical length longer than 25 millimeters in half of the cases, and therefore it may be a reassuring finding. And that the standard method of measurement, where you use the straight line between the internal and external os, will underestimate the cervical length in those cervices which are curved. And their recommendation really is that if we find a deviation of the canal of more than 5 millimeters, you either trace or use the sum of the two straight lines that essentially follow the curve. And I'm sure most of the people who do TVS and cervical length assessment will be familiar with what I'm referring to. And then you'd see from the 2 images that I posted with regards to the abdominal ultrasound scan, some are reporting the funnel length. In as much as those parameters can be measured, but they've been shown in some instances that they may be unreliable and bring quite a lot of controversy with them, such as the funnel width, the funnel length, whether the cervix is post anterior and posterior with the cervical angle, the position, whether it's horizontal or vertical, the vascularity, cervical index, and the funnel shape. So all these things have been shown that they may have some correlation to the outcome in that patient, but they are, in some instances, unreliable. Yes, some people want to report on the funnel shape, as you would see on the images on the extreme right there, that when you measure the cervical length or you attempt to image it, you may actually get these different, so the closed normal cell, why in a small funnel, a V, is a more significant funnel that may, in some instances, extend closer to the external os, where a U really is the funnel of most concern. So some people have actually tried to tie the finding of the particular shape to the particular outcome, but again, this has really not been handled. So how should we be interpreting the results? I think there's some background. We really need to think about these things that I'm going to mention going forward. That we know that many patients, even those at the highest risk, have enormous cervical length in the first and early second trimester. So it really depends. So you should really pay attention to the gestational age at which that cervical length was obtained. We know that there is a progressive and natural shortening of the cervix, more so after 30 weeks, even in patients who deliver at term. We know that in the presence of a normal cervical length, funneling above a normal cervix may, in some instances, progress to a short cervical length. And therefore, when a short cervix is detected, the patient's obstetrical history becomes one of the determinants of the precise risk of preterm birth. And therefore, a short cervix does not automatically equate to a preterm We also know that, however, there is a higher risk of preterm birth. Studies have actually found a 40% risk if a short cervix is detected at 19 to 24 weeks, and a 70% risk if it is detected earlier than this. And therefore, if a short or final cervix is detected in a low-risk woman, the probability of delivering at or beyond 35 weeks is 80% or more without intervention. And therefore, a short cervix should not be the only determining factor for intervention. There are some women who are low risk, who may not necessarily need a cervical sacrilege, for example, as a tool of choice or as the hammer of choice. Where am I getting all this? There has been quite a lot of research and evidence that has accompanied where we are at the moment. And I want to hasten to say most of this is controversial. Most of this is still inconclusive, especially with issues around the role of progesterone. So what I'm going to talk about are some of the studies that have informed some of these recommendations that literature is awash with. So what is the role of cervical sacrilege in someone without a prior preterm birth? So I looked at the systematic meta-analysis by Fetal. We actually looked at whether cervical sacrilege was efficacious enough in the prevention of preterm birth in asymptomatic single TB. We like, although she definition was not shortened, length less than 25 millimeters, and no prior preterm birth, sacrilege in this improve their outcomes. But of brilliant findings with that, in those patients, however, who had cervical length lower than 10 millimeters, sacrilege seemed to be quite efficacious in those women. But however, they recommended further studies to increase the quality evidence to confirm these findings. So there has been quite a lot of work that has been done. Then the next question was, how does sacrilege perform versus a vaginal progesterone? Given two patients, what would be the evidence for putting sacrilege in another person and offering the other patient vaginal progesterone? We know from the study that was published in the EJO in 2018, where they really did an indirect comparison meta-analysis where they compared the efficacy of vaginal progesterone and sacrilege. They actually found that these two were equally effective for the prevention of preterm birth in women with singleton pregnancies with a previous preterm birth and the short cervix. And their conclusion was that the choice interventions and the patient or physician's preference. So from the study, they seemed to say sacrilege effective in these two types of women. Then I looked at progesterone and preterm birth. We know, and I'm sure most people are quite familiar with the results of the study of 2016, where they looked at vaginal progesterone prophylaxis and neonatal adverse outcomes in their multi-center double-blinded trial, where they concluded really that vaginal progesterone was not associated with reduced risk, that it had no long-term benefit or harm. Came out, it really seemed to challenge the efficacy of vaginal progesterone. But however, in
Dr. Dube?
2 years after the study, they then did a meta-analysis of individual patient data. So there are quite a number of other studies that actually came. So in this meta-analysis, they actually examined whether vaginal progesterone prevents preterm birth and in asymptomatic. Hello? Doctor, can you hear me?
There are glitches. I think your network has problems. Sometimes we can hear you. Sometimes you are actually inaudible. And you are also almost time up, left with about 2 minutes. I think we might have lost Dr. Dube there. That's okay. We'll try to contact him. Can we have Dr. Chirume? May you kindly share your presentation? You'll be our next presenter. I'm looking at the chat box. There are no questions currently. So anyone who has questions, please kindly put them into our chat box. And then we will read them out and the presenters will respond to them. So our next presenter is going to be Dr. Christopher Chirume, who is going to present on COVID-19 in pregnancy. So Dr. Christopher Chirume is registrar who is a final year, writing, I think, in about 2 months' time. He is going to be presenting on COVID-19 in pregnancy. Dr. Chirume, it's your floor. Thank you.
Okay. Thank you very much, Dr. Wenge, for the kind introduction. So I'm going to present a case of COVID-19 pregnancy. So we are getting used to the virus, but this novel virus, it brought in a lot of unknown to the expecting mothers. So I've been working at the COVID center for more than 2 years now, seeing this woman every day. They will be asking all sort of questions to say, how is this COVID going to affect my baby? Doctor, I'm gasping for air. Is my baby also gasping inside?
Sorry, Dr. Chirume, sorry, Dr. Chirume, to interrupt your presentation. Can you put it in slideshow?
Slideshow, okay.
Yes.
Full
screen?
Full screen.
Yes.
Yeah. Is it okay now?
No, but yeah, now it's okay. You can proceed.
All right, thank you. Okay. So we got lots of questions from our mothers with COVID-19 who are pregnant to ask that what's the best way? How can I be assured that my fetus which I'm carrying is safe inside? Is there any evidence? Or if there's no evidence, are there any theories or hypotheses or even observational from other studies trying to come up with a way of assessing these fetuses of COVID-19 pregnant woman? So on this case, I will try to share some of our experiences on some of the fetal effects which COVID-19 causes. So I'm going to present Mrs. PM, a 40-year-old mining engineer. We saw her when she was in her 4th pregnancy. Unfortunately, she had a previous macerated stillbirth and miscarriage. The circumstances around those were not quite clear, but with a 1 health child at home. She didn't have any chronic illnesses. She booked early this current pregnancy. There was no gestational hypertension reported on the antenatal visits or diabetes, and she didn't have any autoimmune disease. She was referred to the fetal medicine unit at 29 weeks of gestation after she was admitted 4 weeks prior at a COVID center being managed for severe disease. She was not vaccinated. So she was referred from that center after parental inquisition, where there were lots of questions which were asked to the gynecologist. How is my doing since I had COVID? Is there anything which can be done? Then the gynecologist a patient to the fetal medicine. No aneuploid screen was done. So in initial assessment at 29 weeks, if we are to look on our far left where we're doing fetal biometry, we can note that the head circumference, abdominal circumference, as well as the femur length, they were all in the normal range. Even the fetal weight, they were all in the normal range. But in terms of the Dopplers, if I look at the Dopplers, the umbilical artery Doppler, the PI was quite high, greater than the 95 centile, which is quite high for this gestational age. And the mid-cerebral artery was on the borderline low for this gestational age. And if we're to look at the uteroplacental flow, you can see there was an inversion on that diagram on the placental, uterine placental flow to show that there was abnormalities on the Doppler flows on this first visit. So the other summary of the findings on this initial visit was the amniotic fluid was normal, the ductus venosus was normal, the umbilical artery Dopplers was normal, but the placenta was thick and it was a grade 3 placenta, which is quite abnormal at gestational age. But there were no fetal defects which were identified on this scan, and there were no fetal features suggesting of infection like calcification in the brain or the liver or even ventriculomegaly. So at this point in time, a diagnosis of fetal growth restriction was made with abnormal Dopplers. So it's quite important at this bulletin to say that not all babies who are who had fetal growth restriction are small for gestational age, which means that at scan, the estimated fetal weight might be in the normal range, but if there is abnormality in the Dopplers, a diagnosis of fetal growth restriction should be entertained. And we thought this was secondary to placental insufficiency, acquiring COVID placentitis. So the plan was to order a Tochi screen, which came up negative, and to do weekly fetal Doppler surveillance and a 2-weekly growth monitoring, and the patient to have home blood pressures monitoring. So on further surveillance of the fetus, we saw again after 2 weeks, that was at 31 weeks, the weight remained almost static. And on the subsequent visit at 33 and 34, there was a small rise. The baby gained a few grams, but still on the lower end. And that mark there at 37 weeks, this was the birth weight after they deliver, again indicating that this fetus was compromised in the intrauterine environment. So at 34 weeks, when we did also that biometry, also did the Dopplers, and we noted that the umbilical artery was still abnormal with a high PI and high resistive index, and the mid-cerebral again on the lower end, again showing that there's evidence of abnormalities on the Doppler as we continue to make surveillance of these features. So the plan after that 34-week review was to review again in 2 weeks with these findings, with the aim that at review, the umbilical artery still showed a high PI on that review at 36 weeks. And delivery recommendation was to be delivered at 37 weeks, where she later on delivered a baby boy with a birth weight of 2,600, Apgar 9910, and steroids were given before the delivery. I know it might be controversial about the use of steroids at 37 weeks, but it should be individualized. There's still a benefit in a small proportion. So the baby was later admitted in NICU after the delivery by cesarean section at 37 weeks, as the parents wanted delivery by cesarean section, and she received ventilation with CPAP for 1 day. But unfortunately, the placenta was not sent for histology. So going into literature, trying to find out, is COVID going to affect this fetus or the placenta, in what way? Lots of papers have been published. I think up to date, more than 29 papers have been published, trying to zoom in into the effect of COVID at the placental level. And it's quite a spectrum of things which COVID causes. And none of them is a pathognomic for COVID. So it's as we know that COVID, it affects the respiratory system, but also there's effect on the vascular system. As we know that in the endothelial system, there are angiotensin-converting enzymes, which that COVID virus uses, and there's destruction of the endothelial tissue at a vascular level. So this doesn't spare also the placenta, yet we also have destruction of the endothelial tissue at the placental level with formation of microthrombi. And with that, there's hypoperfusion of the placenta, and also there's increased resistance to flow, which means that if we do the so in literature, they also noted some inflammation, which also are caused by the virus, ranging from inflammation at the decidualitis, inflammation at the villus, or even at the intervillus space, where you got diffuse infiltration of the monocytes, which we call histiolytic intervillitis, a feature which was first described by Labrere in 1977. We can still see that kind of a picture in COVID-19. So it's a spectrum of the changes which happens at the placental level. So this study was done by Shantz et al. In 2020, where he noted that at placental level, there's decidual arteriopath and features of maternal vascular malperfusion from COVID-19. Then another study which was published last month by David et al. He noted also that there's destruction. He was looking at a number of stillbirth and neonates which were born to mothers who had COVID-19. And out of the 68 cases, he found out that 66% of those placenta from those stillbirths and neonates, there was some placental insufficiency and placentitis in those. This was a study done in 12 countries. So another study also done by Anaki was trying to look at the Doppler study, Doppler changes, since we're at fetal medicine, where we interpret these Dopplers. And they noted that there is an increase in the pulsatile and resistive index in the umbilical arteries for this woman who had COVID-19 as compared to the control. So with that in mind, after having our case and also some review in literature, we can therefore hypothesize that severe COVID-19 infection may cause placental insufficiency. So we therefore recommend that for these high-risk women with COVID-19, there should be a proper growth assessment of the fetus, as well as the Dopplers. It's not enough to just measure the fetal weight, as we have seen that the fetal weight might be normal, but the Dopplers might be abnormal, showing that the fetus is having effects of placental insufficiency. So this woman who are high risk with severe COVID disease should be assessed properly. And also, those placentas after delivery should be sent for histopathological review, so that at least we gather more information in terms of the effects of COVID-19 at the placental level, as well as the subsequent fetal growth restriction. So I would want to acknowledge the FMU team and the fetal clinic team and everyone for listening to my case presentation. I think I'll end here and entertain questions.
Thank you very much, Dr. Chirume, for a wonderful presentation. Are there any questions for Dr. Chirume or for any of the presenters we have just presented? I am not seeing anything in the chat box, which means all is clear and no one has any questions. May I ask you, Dr. Chirume, to stop sharing your screen so that Dr. Werenga can start sharing his screen as he prepares to present on fetal growth.
Don't worry about it.
Okay, no questions. So I'll introduce Dr. Werenga. He is not new. He has been leading our scientific sessions, scientific committee in ZSOG. So he's a specialist of Gyne and also a subspecialist in fetal maternal medicine, the founding member of Fetal Medicine Foundation of Zimbabwe, and has been leading the setting up of the fetal medicine units at Parenyatwa and hospital. He has managed to mentor a couple of obstetrics and obstetricians and gynecologists, and has been at the forefront of all these teachings that are happening for the midwives, for the other doctors, and trying to make sure that the modality of ultrasound scanning, which is an important tool in the management of women, is made available, especially to the poor and at the forefront in the antenatal clinics. So Dr. Werenga, it is your floor. You can go ahead. There's a question, sorry, for Dr. Chirume, if he's still around. There's a question from Mr. Chuora. What was the final outcome of the baby, Dr. Chirume?
Okay, thank you, Dr. Chuora, for the question. So the parents requested for a cesarean section, which was done at 37 weeks, and the baby had good outcomes, 9-10. Now the baby is healthy and is at home.
Okay, thank you very much for that. Okay, Doctor, over to you, Dr. Werenga.
Thank you so much, Dr. Werenga. And actually, it's almost good afternoon. Good afternoon, everyone. It is a pleasure for me to be presenting today. I've chosen this topic. It's a very big topic. I know that I'm not going to be exhaustive in addressing this topic, but I've decided that throughout the ZSOG meetings, I want to be talking about fetal growth restriction throughout this whole year. The reason for this is what you are looking at. Believe you me, fetal growth assessment is not being done the way it should be done. Most babies are being missed. This is why when you see the reason why our babies die, if you look, almost a third is due to birth asphyxia. And there is this group of unexplained where they could be hidden. And they may also be here as well, where the preterms are. And if you look at the cause of neonatal death, it is a local, I don't know what to say about this, but we cannot say hypertension causes the baby to die. It is fetal growth restriction, which may lead to hypoxia, which causes these babies to die for women with hypertension due to the high risk of placenta insufficiency associated with the hypertension. So it is this kind of data presentation that makes us relax and think that we are practicing obstetrics the right way. So again, why is it important to do fetal growth assessment? We know that if we are able to pick up the small babies, we can actually put these babies under surveillance, time their delivery, and reduce the mortality and the morbidity by a factor of 4 to 5. And in terms of being of missed babies, it is known that babies are missed. Even in countries where ultrasound is being done at a relatively better scale than ours, you can look at this audit from England, where you can see that amongst the high risk women who had serious scans, about 39.3 was the case of missed babies. Then in the low risk category, we had scans about 24% were missed, and low risk, we had no scans, 18%, and so forth. So the fact that small babies are being missed means there is something which you are not doing right in terms of fetal growth assessment. We should also be aware that being small on its own is a very big problem, not only for in utero life, but also for extrauterine life. I'm grateful to Professor Chauke. He has already introduced to you epigenetics to say there is metabolic reprogramming of genes that occurs if we are starved in uterus and you don't get what you are supposed to get. So babies who are small in uterus are at high risk of all these very bad conditions. You can see for yourself, none of us would want to have these kind of conditions. But we are saying being small is not a good thing at all. I like the question that Dr. Chora asked. That question can never be answered successfully now. We have to answer probably retrospectively when this baby is around 8 years and we say this baby really lived its life in the normal way. But it could still be at risk of metabolic syndrome, type 2 diabetes, and all these are bad conditions. This is why it is important to realize that baby's growth has to be monitored. Before I go on, how do you monitor babies? Because most of the scans that obstetricians get in their rooms, they do not say anything about fetal growth assessment. What the scan tells you is that there is a baby in there. They tell you where the placenta is. They tell you that there is some amniotic fluid. On top of that, they will tell you that the baby weighs 2,200 grams. But 2,200 grams as a value means nothing. It is just an arbitrary figure. 2,200 grams is okay if the baby is 30 weeks, but it is not okay for a baby who is 35 weeks. So it is this kind of incomplete reporting or incomplete ultrasound scan assessment that has led to poor fetal growth assessment. Let's start with the definition. We use an arbitrary cutoff of saying below the 10th centile, these babies are small for gestational age and we need to investigate them for fetal growth restriction. However, we all know that there is a definition which we all agree that if the baby fails to reach the potential or its genetically determined or predetermined potential, it is a small baby. But the problem with the above definition is that it doesn't have cutoffs. Nobody knows what kind of genetics that a baby who is in utero is predisposed to produce. It is extremely difficult to apply clinically. Then we have a situation whereby we and our colleagues, the pediatricians will tell you about these cutoffs and say the low birth weight, very low birth weight, early, extremely low birth weight. But if you look at the charts that we use in fetal medicine, you can see that there is a group of patients who may be low birth weight, who are at 34 weeks and weigh 2.2, who are not indeed fetal growth restricted. But the same term is going to be applied to a baby who is 40 weeks and probably 2.2 kilos again. Certainly, this baby who is preterm for one reason or another, which is not placenta insufficiency, the baby of this brain may not be fried by hypoxia, while this baby who is 2.2 but 40 weeks, who has been exposed to extreme hypoxia, this baby's brain could have been fried by hypoxia. Certainly, these babies cannot be taken as same babies. So there are some of the controversies that we do have. And the fact that the baby is 2.5 kilo does not mean that the baby is normal, because I know obstetricians, they just say arbitrarily 2.5 kilos is okay. But if a baby is 42 weeks, certainly 2.5 kilos is a small baby, as you can see from the charts. Then if we go on to this chart, you will learn that it is not all small babies who are necessarily small for gestational age. We still have small babies who are appropriately grown, but who fail to maintain their growth trajectory. So fetal growth restriction, it's extremely difficult to be precisely cut off. But we in the country, we should be doing the basic. The basic, that is, at least we should be able to identify babies who are small for gestational age, which most of the reports which you are getting, they are telling you nothing about the center of the baby. All they are telling you is 2.4 kilos. Right, then the next question is, which formula do you use? This applies to those who scan. If you do scan, you find out that the machine has got all these formulas. We sometimes use all of them depending on the circumstances. For example, a baby who has anencephaly, you are not going to be able to use BPD and the circumference, so I'm going to use that formula 1. But I'm saying in routine screening, which formula should we use? It has been shown by these studies that the formula of the least mean percentage of error is Hadlock formula 3, which has got BPD, which has got head circumference, AC, and female length. What we mean by mean percentage error, we're saying if we do it close to delivery, it's more likely to be closer to the actual weighted delivery than if we use any other formula. So this is the reason why in the fetal medicine units, we use this formula to calculate the estimated fetal weight. Then there is also a controversy, which people normally use to say, which parameter should we use to screen for small babies? Should you be using AC or estimate of fetal weight? However, it is acknowledged in most papers that serial estimate of fetal weight measurement is as good or better than serial AC in predicting adverse outcome. Then the fetal weight is also more sensitive and specific than other measurements for detecting smallness for gestational age, but can have a large random error. And the other thing, good thing about estimate of fetal weight is that we at least we have a reference for those babies we do a few days before birth. We have a reference because no one measures baby's abdominal circumference after birth to say, if this baby was IUGR, can I see what the abdominal circumference is after birth? But everyone measures the fetal weight. Then which chart to use? There are 3 kinds of charts that the world talks about. We have the customized growth chart. The customized growth chart recognizes that certainly a woman who is 150 centimeters in height cannot have the same baby weight as a woman who is 185 centimeters in height. The same way where a woman who weighs 50 kg cannot give birth to a baby with the same weight range as a woman who weighs 90 kg. So this is the recognition that all these factors do affect growth, and also the number in terms of the rank to say, is it baby number 1, is it baby number 2, is it baby number 3? So we have these charts where you can actually input all these. This one called oddbook.net. If you go to this website, you find it, where you can actually put in the parameters of the baby, the weight of the baby, and the woman's characteristics, and the gestational age, and the estimate of fetal weight by ultrasound scan, and see where the baby is. There are proponents and antagonists to this kind of fetal growth assessment. Then we have the population-based charts. The population-based charts do acknowledge that different populations show kind of a different growth trajectory. And this is shown on these charts here, that if you look at the non-Hispanic chart, non-Hispanic black, non-Hispanic white charts, they are certainly different in how they move. The same way, we do have some standard charts that have been designed by a number of studies over the last years with the intergrowth 21st and the WHO charts, which are also interposed here. And these charts, they are no way showing the same kind of growth velocity. So there is a debate to say, should we standardize how we monitor babies? Which kind of chart should you be using? Should you use your population chart to say Zimbabwe, we should be using our own chart because Zimbabwe women are different? Or we should just say one size fits all and all women are the same? This is part of the growth chart, which is mainly in the UK, but I will just jump it and go into some of the arguments, and I'll tell you what the position is. it has been shown in this kind of studies that there is a better correlation between SGA defined by carcinoma center and perinatal death than any population-based or one-size-fits-all standard charts. These are some of the conclusions from these studies. Then customized charts improve estimate of fetal weight assessment and reduce false positive diagnosis of SGA. However, those who are doing the growth charts, which is also another customized chart, they've argued that 1,554 babies were SGA according to the Hadlock fetal weight curve, which is what we use commonly, which is in the machine. However, 864 of these, or 55% of them, were not SGA if the growth curves were used. That is the customized chart. Then the intergrowth, people say it has shown that there is unrepresentative rates of SGA, which is 4.4%, and LGA, and poor correlation with outcome. These are standard charts, which have recently been studied and are now used in other centers. So there is an ongoing debate to say which chart should we use, and what is our position as fetal medicine. We are saying currently, most of our machines have got Hadlock charts. Where we are as a country in terms of fetal growth assessment, we are still very far. We are still relying more on the Simviso-Funder height assessment, which you know that at best, it may perform up to 30% of detection rate. So this is where we are still. So we still recommend that people use the Hadlock charts in their machine while we are conducting some studies on these charts until we know, or until we could come up with our own customized charts and test it. This just show you our local data. This is our local data. We just plotted our local data on the Hadlock chart. So this is how Hadlock chart is classifying our patients. The 875 patients, this is now private sector data. If you look at the private sector data, you can see that quite a number of babies are being classified as small using the Hadlock chart. These arguments have been advanced in other countries that Blacks, they tend to have smaller babies than Caucasians. So that if we apply the Hadlock chart on them, more babies will be classified as small. This is what we are seeing from the local data of 785 patients. Then when I show you the private sector data and the public sector data from the FMU, the 8,488 patients, you can see that here, more and more babies are actually being classified as small using the Hadlock chart. On the earlier gestation, more and more babies are actually being classified as big. Of course, we still need to verify some of this data here, especially the second trimester data. But what we are saying is, these charts, are they appropriate for us, or our population is such that we are having small babies? We know we work in a high-risk center, but the classification of smallness using these charts is something that we need to investigate. Then we decided to put the same data from the private clinic into the WHO chart, the new WHO chart. This is how the WHO chart classifies our babies. You can see that in the early gestation, more babies are actually being classified as small using the WHO chart there. And as we go towards term, very few babies will be seen as small for gestational age. And this is the intergrowth. The intergrowth fairly fits kind of our patients. It shows that it's now fitting nicely our patients, but it could be missing the small babies because we are in a high risk center. We expect more babies to be below the third center for the intergrowths there. So these charts, it's difficult to compare apples and oranges. You can see they're using different centers, but this is how the charts sort of classified our own babies, which we see in the fetal medicine units here. So you can see that there's a difference in how they classify them, but it's difficult to compare because the other one is using the 5th and 95th, Hadlock is using the 10th and the 90th, and the intergrowth is using the 3rd and the 92nd. But you can see how different these charts are. So it is still a very big issue. Having shown you our work, most international guidelines recommend that an effort should be made to try and pick women who are at risk of small babies, so that these women can be screened, can be given a different form of surveillance to women who do not have this risk. So all identifiable risk factors should be looked for. Then these women who are at high risk, should be subjected to fetal growth assessment or fetal growth scan, including umbilical Doppler from 26 to 28 weeks. And this should be done ideally every 4 weeks if there is no problem. But of course, if the woman has a chronic condition, hypertension, and so forth, this may need to be done as close as 2 weeks. Then women who may have 3 or more minor risk factors, which they describe as minor risk factors, should be referred for uterinatal Doppler. But we recommend that at least a uterinatal Doppler should be done, especially in the second trimester scan, to see women who have a high umbilical PI, so that they could be subjected to fetal growth assessment. Then women who have Down syndrome, and they happen to have a low PAPI, less than 0.4 multiples of median, should also be considered to be at high risk, because normally these women, they have small placentas and they're at risk of small vaginal age. I have good news for you. The good news is that this is private sector cohort, local cohort, where we analyze 949 women. Look at their booking status. It is amazing. It mirrors what we find in Europe and probably the Americas. 86% of our women actually book in the first trimester in the private sector data. I'm not sure, maybe our clinic is different profile from yours, but we are in the private sector. This is what we have come to realize from our data. So close to 90% of patients actually book early, so that screening can actually be offered for these women, and they can be offered growth scans. Then in terms of dating, we actually perform better than what I used to think in the private sector. 70%, about 70% of women are actually being dated using the T1 scan. That is the first trimester scan, which is where we want to be, because LMP method, we know that in about 40% of women, they will not fulfill the Negus rule criteria for dating. So 69% is quite admirable. So what this means is that it is not the women who are not presenting well enough for them to be offered fetal growth assessment in the right way, but it could be our methods of fetal growth assessment, which is what I want to address now. So what are the steps in doing fetal growth assessment? First of all, every pregnant woman should be assessed whether they are low or high risk. If they're in the high risk category, the high risk should be defined to say what high risk are they of. Are they at high risk of FGR, preeclampsia, or so forth? Then the pregnancy gestational age should be assigned. Then fetal biometry, of course, should be performed, and estimate of fetal weight calculation. Then the nomogram should be checked for all parameters. It is of no use for a scan to report and say AC corresponds to 22 weeks. It means no use. What is 22 weeks? I mean, what does it mean to say AC 240, 33 weeks? This is what the scans that obstetrician get in their room say. The scan should tell you the centile and say this tummy is on the 5th centile, is on the 20th centile, is on the 50th centile. Not to say it's 22 weeks. It means nothing. Then if SGA, that is if there is FGA on the estimate of fetal weight, then these women should be subjected to a Doppler. You know, somehow, I don't know who did this, but in this country, people have conspired to make Doppler assessment a special examination. Doppler assessment is a standard obstetric ultrasound examination. There is nothing special about doing Dopplers on patients. So it is standard that whenever fetal growth is being mentioned, Dopplers should also accompany that report, not the other way around, to order them specially, because they are being made special. You see, obstetricians actually now, right, to say fetal growth assessment plus Dopplers, because when they were sending them for fetal growth, Dopplers were not being done because somebody decided that they should be special, but they are not special, it's standard. Then if LGA, GTT should be ruled out to exclude gestation diabetes. Then if Doppler is abnormal, then of course fetal medicine need to be involved in the care of these patients, or a person with fetal medicine training who knows how to interpret the Dopplers, how to do proper fetal surveillance, should be involved in the care of these babies. Of course, if there are fetal abnormalities, fetal medicine should be involved. Then let's go through dating, because this is where probably we miss it in most cases. Let's start with scenario 1. LMP is LMP dated. If the woman fulfills the Negus rule, we can use the LMP. That means we should do it properly. Are you having a 28-day cycle? Are you taking contraception? And are you sure of your LMP? Then if the woman has a first trimester scan, we are now recommending that use the first trimester scan where a CRL has been done. So use the first trimester scan date so that we can standardize our dating, so that we can compare our results to those of others. Because you cannot practice in our own way. We can't compare what you are getting to what others are getting, because we are just dating them in a non-standardized way. So scenario number 3, there is no T1 scan, LMP not sure, T2 scan done, use EDD from T2 scan, that is head circumference dated, not the summary of the machine. The machine does not think, do not use the date the machine produced, use the head circumference if we are to date the pregnant, the second trimester, for a woman who is not sure, who has missed their TT1 scan. Then IVF done, use the IVF date. I'm happy the IVF team are here. Please kindly supply the women with the due date. Sometimes we see IVF women, the due date, they don't even know it themselves. But we kindly ask you to supply IVF date. It is not standard to date IVF pregnancy with scan. The IVF date should come from you guys, the reproductive health medicine team, the due date, so that we can know where the pregnancy is. Then the scenario number 5, first trimester scan done, low risk pregnancy, you can assign using head circumference. If there is no biometry asymmetry, you rescan again in 2 weeks. This is third trimester now. This is a woman who comes in third trimester. Scenario number 6, no previous scan, LMP unsure. This is a high risk pregnancy. You assign it using head circumference. Then you check the charts if biometry is asymmetrical. Then of course Dopplers have to follow. To round up, then how should we identify those who need fetal growth assessment? This is what we need to look for when we are doing history: hypertensive disease or pregnancy, previous early onset preeclampsia, those who delivered early, then previous stillbirth, chronic renal failure, screening positive for preeclampsia and FGR. Our fetal medicine units are now screening women for preeclampsia and FGR. So sometimes you may see women written, screen the high risk for preeclampsia, FGR for growth assessment. Please don't tell the woman that you don't need them, because babies are dying, because small babies are being missed. They need growth scan, these women. Small for gestational age, diabetes mellitus, epilepsy on medication, and unphospholipid syndrome and lupus. How often should scan be done? We are recommending 28 weeks, 32 and 36 weeks. Of course, the surveillance plan is modified by the abnormalities found on the routine growth scan. Then for twins, it's a totally different story. For twins, all twins, if they are monochronic, from 16 weeks, we're bringing them every 2 weeks so that we can screen for TTTTS as well. Then for dichorionic, from 20 weeks, we are screening everyone from every 4 weeks, because they're at high risk of selective fetal growth restriction in either of the twin. Then low risk women, and I would like to thank the team, FMU, FMZ, Fetal Clinic, and thank you everyone for your listening. Bye-bye. I have to wait for questions. Thank you.
Thank you very much, Dr. Weringa, for a wonderful presentation. Any participants with questions? We've come to the discussion session, so you can type your questions into the chat box or the question and answer segment. And then for the panelists, you can raise your hand, and then we can ask questions. I just have one question to Dr. Madembo. Do we have any scheduled ultrasound scan trainings that are scheduled maybe per quarter or for the rest of the year, where participants who are interested in learning obstetric ultrasound scans can actually book and know that I will be attending this particular session on such and such a date? Thank you.
Okay, thank you very much, Dr. Wenge. I think Dr. Verenga can assist in responding to that question.
Dr. Wenge, we do hold sort of regular training sessions for groups, for bigger groups of participants. But for individual participants, we have an open door policy. Anyone who wants to upgrade their skills or to improve their knowledge can just write to us. Our contacts are FMZim at fetalclinic.online. You can send your requests there. We will organize for you to come to our unit and be trained any day, anytime. So we have an open door policy for now. But if people are a group, then in that case, we do those group trainings.
Okay, thank you very much.
Dr. Wenge, to just emphasize that I know my presentation do not address all issues, but like I said, in every ZSOG, I want to be talking about fetal growth from all different angles. Yeah, so I will address the other issues which I jumped on this presentation, but this was a teaser of what will be coming in the next meetings.
Then just a question also to Dr. Madembo concerning from the outcomes that you presented, the results. My question is to do with those participants who needed some form of consolidation and those that did not manage to meet like the specifics to say that they are qualified in doing certain measurements. What are the plans to do a follow-up on them, or what are the plans for the consolidation? Any mechanism put in place to make sure that they become competent?
Okay, thank you very much, Dr. Wenge. As you are aware, ultrasound scanning, this is a competence-based training. And yeah, it's not about reading a lot of books. Yeah, it's good to read books, but it's about scanning time. The more someone scans, the more someone polishes and consolidates their skills. So what has been happening is after every training, each team would go there with their machine. So as they go and practice, we are very sure that skills will get consolidated. Probably with time, yes, there may be need for a supporting and supervision by looking at images that people have taken and also seeing whether they are meeting the expected criteria for like the basic planes, the head, circumference, biparietal, femur, abdomen, etc., etc. So there may also be need to time to have support and supervisory visit and making kind of an audit at the images that people will be taking with time. Over to you.
Okay, thank you very much. Dr. Henson Dube, I hope you are still online. So there is a request that you didn't manage, obviously, to go through your presentation due to network issues. Can you kindly prepare to just give us a take-home message from your presentation and what you left out? And in the meanwhile, whilst you gather your thoughts, Dr. Dube, we'll ask Dr. Verenga to respond. So Dr. Choto says, thank you very much for your good and insightful presentation. My question is around ensuring there is accurate monitoring of fetal growth in resource-limited settings. Do we have screening algorithms that can be used in our clinics or district hospitals where they may not have this sophisticated equipment?
Thank you so much, Dr. Choto, for this great question. Before I answer your question, let me sort of buttress something which Dr. from Dr. Madembo. What we did during the training is that most of the participants were coming in pairs. So we managed to identify that actually it was okay. It was by coincidence that one of the participants from one of the sessions would be better than the other. So what we did was we sort of advised them to go and work in pairs, help each other, close the gap that we had noted during the training. So we asked the more competent guy to be in charge in the first few days, few weeks, until the other one clears their gap. So that is one of the strategies that we implemented when we noted that there was a disparity in the competence skills. Then the question that you asked, the question that Dr. Choto asked, what we did during the training, actually, let me say ultrasound is not a sophisticated equipment. It is the modern day stethoscope. Because if we don't change this way of seeing things, you always think it's a sophisticated equipment. But it is a modern day stethoscope, which is now available even as low as rural health center. You heard what FHI 360 did, that they purchased machines for the rural health centers, because this is where it should be for babies to be assessed properly, because practicing obstetrics of guessing, it belongs to the 1960s actually. People should be sure that the placenta is low-lying, should be sure that indeed this is a breach, not to suppose. So what we did is we taught them how to do fetal growth assessment. We gave them templates that they use to assess. We taught them to interpret growth. We also taught them how to do growth, to do dating assignment. We taught them this algorithm, which I went through just now, how to assign the dates on a woman, because you cannot comment growth if you cannot assign the dates to a pregnancy. So we actually took them through this during the training and also during the practical sessions. We're able to take them through this. So we believe that with the application of this, they'll be able to pick more growth. But remember, growth assessment has always been done, but it has been done by one of the most crudest way, which is symphysis of fundus height measurement or height of fundus estimation. But we have already said that, unfortunately, for the high-risk group, this method is not good enough, the symphysis of fundus height measurement, to use it as a way of monitoring babies who could potentially be small. The high-risk group will need ultrasound to monitor. The low-risk group, probably, these women may not need even monitoring, to be honest with you, the low-risk group, but we know that there will still be a substantial small for gestational age babies. So, yeah, probably this is my response to that.
Yes, thank you very much for that response. And there's a follow-up. Dr. Choto has an interesting comment. So you said, are we also planning to roll out some of these innovative skills as midwife or nurse-led interventions?
Good question, Dr. Choto. Actually, fetal medicine unit is anchored by midwives. On top of that, fetal medicine trainers, our trainers, let me say 80% of them are midwives. The people who are trained, I think you saw Dr. Madembo's presentation, that 80% of the people who are trained in obstetric ultrasound are midwives. So I do believe that midwives are the backbone of any kind of, maternal women's health intervention for it to work, because they are everywhere. Obstetricians and doctors, they're not everywhere and they come and go very quickly, but midwives are stable. So we do believe in that. And this is why you see, if you go to fetal medicine units now, the people who induct you, people who teach you how to do basics are midwives. We have trained and they become extremely competent and good what they do.
Okay, I hope Dr. Choto, you have been answered. Are there any other pressing issues? Because I think we have
Prof. Chauke's hand is up.
Prof. Chauke's hand is up. Sorry, I cannot see it. Please, my apologies, Prof. May you please go ahead.
Thank you, Chair. My question is directed to Dr. Verenga, and congratulations once again for the great work. I'm not sure whether you are familiar with ambiflow, and I'm referring to this when it comes to the concern about intrauterine growth restriction. And my question to you is, do you see any role of an ambiflow in the Zimbabwean context?
Doctor, sorry, Prof. I didn't get the question. You said ambiflow.
Yes, it's a hand-to-head Doppler. It's a very cheap device.
Yeah, ambiflow. I've heard of it, but unfortunately, I do not have experience with the ambiflow. We've not used it locally, but I've heard stories about it. So I don't think I have much comment because I've not used it. But it's something that I think is worth exploring in our situation, because not all centers may be able to have ultrasound. So it's an idea which I think we have to explore.
Thank you.
Okay, thank you very much. So I think we have slightly exceeded our time. Our discussion was supposed to end at 12:40. So this time we will leave it to our sponsors. May they please start sharing their screen so that they can present something to us.
Thank you, Doctor. Let me start sharing. Can you see my screen now?
Not yet.
Okay, let me just something. Slide.
Okay, so as you prepare, to the participants, our next session is going to be gynecology oncology, and this is going to start from 12:45 to up to 14:10, up to 14:30, when we can break for our lunch session. So please stay tuned and be around. There's more to come from the Gyne oncology team.
Okay, can you see my screen now?
Not yet.
Not yet? Okay, let me
Yes.
just let me exit.
Okay, as you are preparing, Dr. Rombi Makoni, I hope you are ready to take over chairing the Gyne oncology session in about 3 minutes, 5 minutes time. Thank you. Just wait for Melody to share her screen and give us something.
Okay. So starting to sharing. Are you seeing anything now?
No, we are not.
See our presentation. Apologies for that. I'm not sure what's going on here.
All right. No, is it okay if we proceed to the next session, then right at the end of the Gyne oncology session, where you can then try and squeeze in your two presentations, because I see you have another presentation scheduled at 14:05 to 14:10. So you can maybe get a bit of more time there just before lunch, and then you can present the two of them.
No problem, sir.
In the interest of time, yes, thank you. Dr. Rombi Makoni, are you around?
Very good afternoon to you all. My name is Rumbizai Makoni. I'll be leading this discussion. We will be discussing gyne oncology. So to start us off, we're going to have a presentation from Dr. Chipo Gwanzura. She will be available to answer the questions, but we're going to play her presentation. Vincent is actually organizing that for us as I give the profile for Dr. Gwanzura. So Dr. Chipo is an obs and gyne in Harare. She has got clinical interest in minimal access surgery. Her research goals are to reduce female morbidity and mortality. She's the recent past vice president of WATOG. WATOG is the World Association of Trainees in Obstetrics and Gynecology. She currently chairs the Public Relations Committee of the Zimbabwe Society of Obs and Gyne. She is also on the Minimal Access Surgery Committee of FIGO. She sits on the Knowledge and Evidence Working Group of PMNCH, which is Partnership for Maternal and Newborn Child Health. And this year, she's also joined the IMAP. IMAP is the International Medical Advisory Panel. She will introduce to us this afternoon the Awaken study. So we're going to leave this time to Dr. Gwanzura. Vincent, if you can proceed and play the presentation. Thank you. Hello, Vincent.
Yes, hello, Doc. Is it audible?
Okay. No, we can't hear anything. We're just seeing the folder with all the files that you have.
Oh, is it?
Yeah.
Okay. Let me try to log here and see what's going on here. Let me stop share. Okay, video. Just a little bit, documents done.
Good day, ladies and gentlemen. It is my pleasure to introduce to you the African Awareness of Cancer and Early Diagnosis Study, the Awaken study. This is scheduled to launch in Zimbabwe in the next couple of weeks. The principal investigators are Dr. Guja and Prof. Chirenje, and my involvement in the study is as a research fellow. This is an NIHR-funded study, and the collaborators are the University of Cape Town, Queen Mary University of London, and ourselves from the University of Zimbabwe. Special welcome to all the stakeholders that will take part in the study within the governance structures, or as clinicians, or as participants. This is the outline of my presentation. By way of background, we know it is estimated that 24 million people worldwide will develop cancer. Of these, 13 million will die. And unfortunately, 75% of these 13 million are from low and middle income countries. And Zimbabwe falls within the category of low and middle income countries. In Southern Africa, patients tend to present late. They are diagnosed when they self-present, and this is usually at an advanced stage, and we know this is associated with poor outcomes. Globally, the key goal of comprehensive cancer control is shifting towards earlier diagnosis. And interventions aimed at promoting early cancer detection, as I said, are being adopted globally but this is happening mostly in high-income countries. So improving timely diagnosis of cancer in low and middle-income countries may actually require different approaches, given the substantial differences between high-income countries and low and middle-income countries in terms of health resources, infrastructure, and medical personnel. In addition to that, we know that the journey to diagnosis and treatment is quite complex, and it's influenced by a multitude of factors. And it is vital to understand these factors in order to develop locally relevant interventions to enable us to diagnose cancer early. So the AWAKEN study has 3 aims, which we'll achieve in 4 years in 3 work streams, and I will explain a little bit more. So the first aim is to assess the time intervals from symptom awareness to referral and diagnosis, and the factors influencing these intervals in Zimbabwe, representing a low-income country, and South Africa, representing an upper middle-income country. So this is the work that we'll do in workstream 1, which is about to start, and we estimate that this will take us about a year. The second aim is to develop 2 e-tools. We are in the era of technology. And these e-tools are set to promote more timely presentation and referral. There'll be a symptom assessment and management e-tool for primary care providers and a symptom appraisal and help seeking e-tool developed for the public. In workstream 3, we'll then evaluate these e-tools to ensure that they are operationally and economically feasible and equitable, they're social, culturally acceptable, and support timely referral. So a little bit more about workstream 1, where we are trying to better understand the current pathway to breast, cervical, and colorectal cancer diagnosis in each country, and the capacity and potential targets for interventions. So we'll conduct 3 studies as part of this workstream 1. The centers in Zimbabwe are located in our central hospitals, Parenya Group of Hospitals, Salim Gabe Central Hospital, as well as Impilo Central Hospital in Bulawayo. And we have also included 2 provincial hospitals, Marondera and Gwanda, as well as Karanda Mission Hospital, being a district hospital that receives many patients with cancer. We'll also recruit from 2 primary care clinics referring to each of these facilities. We may also include Chitungwiza Hospital. So the first study in workstream 1 is focused on understanding the health facilities. So we want to take stock of the current capacities and services for the 3 cancers, breast, cervical, and colorectal cancer. So diagnosis of these cancers. This study will also contribute to identifying strengths and gaps and inform the development of timely referral and diagnosis interventions. It will involve interviewing the facility manager, and our sample size is 15 per province. So we'll recruit facility managers from primary care clinics, the district hospitals, the provincial hospitals, and the central hospitals. The second study in workstream 1 involves interviews with health providers. So this will be done to explore current practices and processes for patients with cancer symptoms. We'll understand from their point of view the challenges, barriers, and facilitators to management and referral of patients with breast, cervical cancer, and colorectal cancer symptoms. We'll try to tease out their training needs, as well as their views on potential e-interventions for management and referral of symptomatic patients. The third study, completing the 3 studies in workstream 1 now, is targeting patients. So these are patients with symptoms for investigation for suspected cancer or those recently diagnosed in the preceding month. So this will be undertaken to understand patient pathways to diagnosis and associated factors. And we'll recruit patients over the 12-month period that I had mentioned earlier in order to attain our sample size. So between South Africa and Zimbabwe, the total sample size is 1,134. Here I've split up the sample sizes in Harare and Bulawayo, but Harare actually includes 3 provinces, Harare, Mashonaland East and Mashonaland Central. So 70 breast cancer patients, 140 cervical cancer patients, and 55 colorectal cancer patients, which is about half the estimated number of new cases that are usually recorded within Harare. And in Bulawayo, 30 breast cancer, 74 cervical cancer, and 15 colorectal cancer patients. So without prior data, it's actually not possible to accurately estimate the sample size required to detect a difference in the intervals between and before intervention. So these samples, in coming up with these samples, we assumed samples of 200 patients per primary care facility, providing up to 800 participants per country, and therefore 1,600 across Zimbabwe and South Africa. I won't go into the statistics of this. So the third study that is targeting patients is actually a cross-sectional study, and we are going to recruit adults aged more than 18 years of age, more or equal to 18, and these will be under investigation or recently diagnosed with breast, cervical, or colorectal cancer. And this is to minimize recall bias. The exclusion criteria are patients who have a previous history of cancer and those unwilling or unable to provide consent. And we'll use a structured questionnaire and explore their socio-demographic details, such as their age, employment status, relationship status. We'll explore how healthcare is paid for, asset ownership, whether they receive social grants. We'll also explore their medical history, in particular, their habit of breast self-examination, whether they've presented themselves for clinical breast examination before, their family history of cancer, their history of COVID-19, HPV cervical screening, and their awareness of symptoms of cancer, as well as explore any barriers they may have faced in their journey to care. We'll also explore when they first recognize their first symptom, when these symptoms change, when they visited their first healthcare facilities, if at all they presented at traditional or religious healers, and if yes, how many times they visited. So in order to minimize recall bias, we'll use calendar landmarking to help them to remember the important dates. So that was workstream 1, comprised of 3 studies: health facility assessment, a health provider interview, and a cross-sectional survey of patients recently diagnosed with cervical, breast, and colorectal cancer. Workstream 2 will follow after workstream 1. So we're looking at about year 2 of this 4-year study. And this is a focus on developing 2 e-tool interventions, as I mentioned earlier, and it will involve a number of focus groups that will help to come up with these 2 tools. And in the third work stream, we'll then evaluate the 2 e-tools across Zimbabwe and South Africa. So this is to ensure that they are operationally and economically feasible and equitable, and that they're social, culturally acceptable, and support timely referral, and to promote the improved assessment of patients with symptoms suggestive of breast, cervical, or colorectal cancer, and to enable efficient referral. And all this I've said is because if we achieve a diagnosis early in cancer, then we are able to intervene more effectively with better outcomes. So in terms of ethical approvals for our study, I'm pleased to report that we have received approvals from the MRCZ, the JREC, and the Research Council of Zimbabwe. We will also obtain written informed consent from the facility managers, the healthcare providers, and the patients. And for our patient participants, so any therapeutic misconception will be addressed by making it clear that involvement in the study will in no way be linked to the care they receive at their healthcare facilities. We're trying to be able to develop an intervention to enable early diagnosis of cancer. We are in the era of COVID-19, so we need to be prepared. So if necessary, we will have virtual interaction with participants. This will mostly be possible with the health facility managers and the healthcare providers, but we will come up with measures to interview patients virtually if need be. And infection prevention and control-based practices and precautionary measures are being put in place. So that's it for my presentation. Feel free to visit the website, www.awaken.online, to read more about the Awaken study that we are launching in the next couple of weeks. Dr. Guja or myself or Prof. Chirenge will now be available to take any questions, and we look forward to working with you all.
Thank you very much, Dr. Gwanzura, for the presentation. Currently, she's having network challenges. So if we've got any questions pertaining to the Awaken study, can we put them up in the chat box or in the question and answer? They will be attended to either by Dr. Gwanzura herself or by Dr. Guja as the discussion goes on. So if you've got any questions, please put them up. Currently, I do not see any questions. So we will move on to the next presentation. And the next presentation is going to be on outcomes of patients being treated for gestational trophoblastic neoplasia at Parinyatwa from the topic says from 2019, but our statistics are coming from 2020 to date. This presentation has been made by the two registrars who are in our firm. This is Dr. Maxwell Chimina, together with Dr. Emily Koti Mokucha. These are registrars, senior registrars who have a special interest in Gyne-Oncology and have been working in the unit for the past year. So I'm going to leave this time to Dr. Mokucha, who's going to be giving us this presentation. So over to you, Emily.
Thank you, Dr. Makoni, for such a humbling welcome. I'm going to present to you an audit that we did as a team in assistance with all the team members from my firm. Okay, it's a pleasure to be with you once again this afternoon. So our audit was basically a clinical audit of gestational trophoblastic neoplasia, which we managed in our firm from the year 2020 up to date. So I have no disclosures at the moment. And this is the outline. We basically look at the introduction, the results, and then we also look at the conclusion. Can you see my slides? Dr. Macroni,
yes, we can see the first slide only. Had you moved your slides?
Can you put it on slideshow? It's not yet on slideshow.
Okay, so I'll proceed.
Are you not able to put it on slideshow?
Yes, right. Okay, can you see my slides, Dr. Makwen?
Yes, we can see, but they are not on slideshow.
Okay, so gestational trophoblastic disease represents a group of tumors arising from the trophoblastic tissue of the placenta.
Hello, Emily.
Yes, I can hear you now, Dr. Makwen. Thank you. So gestational trophoblastic disease represents a group of tumors which arise basically from the trophoblastic tissue of the placenta. So this is a spectrum ranging from benign hydatidiformos up to the malignant gestational trophoblastic neoplasia. So the incidence is very various across the parts of the world. So basically, when one has to diagnose gestational trophoblastic neoplasia, the diagnostic criteria is as follows. So there should be a rise or a static level of serum beta HCGs on patients that we are following up for molar pregnancies. So these are measurements that are done in at least 3 consecutive weeks for you to pick up a rise or to pick up a plateau. There should also be histological evidence of choriocarcinoma at any sites following a tissue biopsy. And some patients who have persistent heavy vaginal bleeding following a molar pregnancy diagnosis with elevated beta HCG levels after a 4-week period of having had suction curettage and a beta HCG level of more than 20,000. And then also in a patient who has all the clinical symptoms of molar pregnancy with metastasis of non-pulmonary or to the lungs of more than 2 centimeters in diameter. So if you have these features in your patient, then you should be able to make a clinical diagnosis of, you should be able to make a diagnosis of gestational trophoblastic neoplasia. Then after diagnosing a patient of this neoplastic condition, you have to allocate the patient a stage, which is stage 1 to 4, and a WHO risk score, which involves multiple parameters in trying to attain the ultimate score. So once you've diagnosed this patient of GTN, basically you have to do investigations. So this includes the baseline hematological investigations of, full blood counts, urea and electrolytes, and you get on those. You then add the thyroid function test, the VDRL, and the HIV test.
Do we still have her online, Dr. Makoni?
She's online, but we can't hear her. I think She's muted. Dr. Mkucha, you're muted.
Okay, Dr. Makoni, we are just fixing up a technological issue.
Okay.
Dr. Makoni, can you kindly please confirm if my slides are moving now?
We can see the slides mentioned introduction.
Okay. Are they moving now?
Yes.
Okay. So, like I was saying, when you make a diagnosis of gestational trophoblastic neoplasia, you have to do the baseline hematological investigations of a full blood count, use and ease, and you have to do the LFTs. Ideally, we want you to do the GGT and ALP. Then you can proceed to do a thyroid function test, and you screen for syphilis. And then just to wrap it up, you also want to know the HIV status of the patient. When you then move to the radiological investigation, so the current standard of care is that you have to do a CT scan of the chest, abdomen, and pelvis. But due to our low resource income status in this country, if these are not available, the patient can have a chest X-ray done and then an ultrasound scan of the abdomen and pelvis. So when you find diseases involving the chest, on CT scan of the chest or a chest X-ray, you have to do an MRI or CT scan of the brain to rule out any brain involvement. So like I said, these investigations might not be available. So in a case whereby the patient cannot have a CT scan of the brain or MRI of the brain, you can then proceed and do CSF beta HCG levels if you have a strong index of suspicion of CNS involvement. So then you can offer the patient a PET or CT scan for unexplained raised beta HCG levels, although you have negative images. So when you're then planning management of this patient, this should be done in a dedicated unit with trained gynecologists, oncologists who are able to manage these patients. So before you offer these patients a definitive management, a take-home message for today is that there is no role of a repeat evacuation of the uterus once a patient has been diagnosed of GTN. So if you then risk score these patients according to the WHO risk score criteria, you divide them into 3 groups, which are the low risk, the high risk, and the ultra high risk. This has a bearing on the ultimate chemotherapy that you're going to offer these patients, whereby in low risk cases, you give them a single agent of actinomycin D or methotrexate, and then the high risk, they have to get a multi-agent chemotherapy of the imaco. Then there's this the subgroup of patients who have an ultra high risk. These are patients who have a WHO risk score of more than 12. These patients are at a risk of developing acute tumor lysis syndrome if you introduce the imaco straight away. So you have to give them an induction chemotherapy of etoposide and cisplatin for at least 3 cycles before you proceed to give them the imaco regime. So surgery can also be used as a management options for patients with GTN in cases whereby a patient is refractory PV bleeding, which is not uncontrollable, or there's massive hemorrhage. You can offer these patients a hysterectomy. Then there are patients who have persistently localized disease and they are refractory to chemotherapy, like lung involvement, any site involvement. You can offer them local resection if you have an experienced and well-trained surgeon who is able to give a complete resection of the tumor. You can also offer this patient radiotherapy, like patients who are refractory and having continuous PV bleeding. And then you can also offer them pelvic artery embolization. So the issue is that to date, there was no audit which was done in Zimbabwe regarding the epidemiology, management, and outcomes of patients with GTD. And we also do not have a gestational trophoblastic disease registry. So in view of this, we carried out an audit as a unit. So basically, we looked at patients who had had a GTN diagnosis from 2020 up to date. We went through their patient files. We looked at the factors that were related to the etiopathogenesis, diagnosis, and management, and also the outcomes of some of these patients. And then we compiled the audit after having done data entry. So these are the results that we managed to find. We managed to find notes and compile an audit on 17 patients in total. So of these 17, 16 patients were basically in the age group of 20 to 40 years, 11 patients, which was 65%, and then 6 patients were in the age group of more than 40 years, which was 35%. From our audit, we did not find any patients who were younger than 20 years. So we also noticed that the greatest number of our patients, which was 6, summing up to 35%, were in the multiparas group of para 4+, followed by patients we had who were para 2, who were 29%. And the lowest group was in patients who were para 1, which comprised of 6%. We also looked at the blood groups of these patients, and from the patients that we managed to have their blood group documented in the notes, about 41% of them, which was 7 out of 17, were O positive, and the least number was in A positive and O negative groups. This also shows a poor documentation in our notes, whereby 8 of our patients, 47%, were in a unknown blood group, which was not documented in the notes. So amongst the 17 patients that we managed for GTN, the greatest number of them, 8 out of 17, presented with being diagnosed of GTN following a post-molar follow-up rise in beta-HCG or symptoms. And then 7 of them had PV bleeding, and then 2 out of the 17 had a histological diagnosis of choriocarcinoma. So this chart basically shows the baseline beta-HCG ranges for these patients. So of the patients that we managed, 6 out of them showed beta-HCG ranges that were between 100,000 and 1 million. And for patients who had more than 1 million beta-HCG levels, there were about 3 of them. And we only had 1 patient whom unfortunately we could not find the baseline beta-HCG due to loss of the initial notes when she came to our unit. So these patients were all assigned a FIGO stage, and the patients who had the stage 3 compromised most in our patients, with 53% of them being assigned FIGO stage 3. And the list was that for stage 1, with only 7% of them, which was 1 patient, being assigned FIGO stage 1 at the initial presentation. So we went on to look at the WHO risk score of these patients. So if you look at this chart, it basically shows that 5 out of our 17 patients had low risk, which was 29.4%. And then this was also similar to 5 out of 17 of our patients who had ultra high risk. And then the greatest majority of our patients had high risk, which were 7 out of the 17 patients, comprising the 41%. From the initial cycle, so from the chemotherapy cycles show that basically for a patient with low risk, they need to receive about 6 cycles for them to have remission or any other follow-up. Then mean cycle for high-risk patients is 10, and for ultra-high-risk patients is 12. So you know that as the risk gets higher, most of these patients would need more chemotherapy cycles in follow-up. So we also looked at outcomes of chemotherapy in our patients. So if you look at our patients who are diagnosed of low risk, 4 out of 5 of these patients ultimately failed first-line single-dose methotrexate, and we had to switch them to imaco. And then 7 of our patients who were diagnosed on high risk were given imaco, and some of them are still on imaco, and some of them went into remission following the multi-drug imaco regime. Then in our patients who were diagnosed of ultra high risk, we have a very interesting case of one patient who failed the first line imaco regimen, so we had to switch her to the second line, which comprised of EMA-EP, which is basically etoposide, methotrexate, actinomycin D, etoposide, and cisplatin cycles. Then 2 of our patients who had ultra high risk, unfortunately had lost to follow up, and we couldn't contact them over the telephone to follow up on them. So in view of the toxicities that are associated with chemotherapy, we would note that most of the toxicities were the hematological toxicities, which are usually the ones of neutropenia, and not only about 5 of our patients had this, which was the same for mucositis. 5 of our 17 patients had this complication. The list was that of sepsis, where we only recorded 2 patients with sepsis, and these patients actually had neutropenic sepsis, so they had both the hematological and the septic complication. And then we had 4 patients who reported alopecia, and we are currently following them up on the cosmesis for that. So we also unfortunately had some losses, some fatalities. We had about 3 of our patients who deceased after a diagnosis of GTN, which was 18% of all our patients. And then, like I mentioned before, we had 2 patients whom we lost to follow up. So of these 17 patients, we currently have 12 patients, which is 75%, whom we know of the outcomes which are outside of case fatalities. So these 12 patients, 4 of them were patients who were diagnosed of low risks. Then they failed on first line, and then they went on imaco, and then they went into remission following imaco, which was 45% of our case of our 12 patients. Then we had 4 patients who were diagnosed of high risk who went into remission. And then from a patient, we have 1 patient who was diagnosed of ultra high risk. She went into remission, and then she subsequently had a twin pregnancy and delivered her twins. And then on follow-up, she started to have an elevated beta HCG levels. She's awaiting to restart chemotherapy again, and she's currently being discussed in the MDT meetings. So in conclusion, we would like to know that gestational trophoblastic neoplasia is a diagnosis which is a condition which is treatable, and there's a very good response to chemotherapy. This should be done and followed up in a dedicated unit of people who are well trained in managing these patients and who are able to follow up these patients meticulously. On the part of the generalist, post-molar follow-up should be very meticulous and should also be in conjunction with the Gyne Onco team where there is need of clarifications in terms of plateaus and rise in beta HCG. So any patient who presents with symptoms suggestive of GTN, clinicians should have a high index of suspicion in these patients with symptoms of GTN. And then we also know that the cost of drugs has a very great impact on the management of these patients, and there is a need for intervention in this area where possible by responsible authorities. So the limitations in our audit was that the record keeping in our system is very poor. We had to search and we couldn't pick up some records of some patients whom we actually knew were being followed up for GTN. However, this is actually being resolved. We now have a data capturing system in our unit that is going to be able to capture all this data of patients that are being managed under the Gyne Onco team. And then we'll also formulate a clear follow-up protocol, as this was lacking in the system. So we're aiming to formulate this and distribute it in terms of patients with gestational trophoblastic neoplasia. Would recommend a radiological support for advanced imaging in patients who are diagnosed with gestational trophoblastic neoplasia, but cost remains a very rate-limiting issue in this case. And also, this does not need much emphasis, as I have already alluded to that financial support for chemotherapy drugs is very crucial and paramount in these patients. And yes, of course, we highly recommend gynecology, oncology training of more obstetrician and gynecologists. Thank you all, and I would open the floor for questions and answers. Thank you, Dr. Makoni. It was such a pleasure.
Thank you, Emily, for your presentation. In the chat box, we've got a question from Dr. Matsire, who is asking why VDRL is a baseline assessment for GTN. So why do we screen for syphilis?
So GTN is a pregnancy event, and these women are young, and possibly once they finish up follow-up, they would want to try again for a baby. So we want to, so we just kind of do some routine tests that are done for women that are pregnant, which is a syphilis screen and an HIV test. And if they are positive, then we have an opportunity to treat them before they try again for a baby after finishing follow-up either for a molar pregnancy or a gestational trophoblastic neoplasia. So we just do it because it's a pregnancy complication and it's part of wake-up for pregnancy.
Thank you, Dr. Guja, for responding to that question. I don't see any other questions. If you've got questions, you can put them in the chat box or in the question and answer. We'll attend to them as we proceed. The next presentation we're going to have is a presentation from Dr. Yamrai Bikwa, who is a senior registrar in the department. She's currently based at Harare Hospital, but she's got interest in gyne oncology, and she's part of the tumor board and has got interest in the issues that have to do with the tumor board. So she's going to present on when to refer to the gyne oncology unit and what you need to do to refer to the gyne oncology unit. So over to you, Yamu.
Thank you, Dr. Makoni. Just putting up our slides. Confirm you can see my slides in slideshow.
No, it's not in slideshow.
Can you see my slides?
The slides are visible, but they are not in slideshow.
Okay, let me try again. Is it in slideshow now?
Not yet.
Okay. Is it in slideshow now?
It's still not.
Okay. Apologies. Okay, that's fine. Hi, Dr. McQueen. Can you see me now?
Yes, now it's in slideshow.
I'd like to welcome everyone who's joined us. I'm going to be presenting on when to refer to the Gyne Oncology unit. We've realized sometimes there's some confusion as to when and how to refer patients. So we're just going to go through this briefly. So unfortunately, our unit is not a dedicated oncology unit. We have to have obstetric patients as well as benign gynecological cases on the ward. So here I've just put an outline of our activities during the week. On Monday, we now have a chemotherapy clinic. We also have antenatal clinic as well. Tuesday is our Gyne OPD day. We meet oncology as well as benign cases. And it's also the day that we prepare our patients for theater. Wednesday, mainly we're in theater. We spend about 4 to 8 hours depending on the cases that we have. Thursday is our colposcopy clinic, as well as review of referrals, including hospital cover, which means we'll be covering maternity as well. Friday is our grand round and the time that we see patients who've been consulted by other teams. And it's also a Gyne OPD day. We've got 2 OPD clinics. So you can understand the pressure that we have. So which patients can we refer to the Gyne Oncology team? All the gynecological cancers, which include cervical cancer, ovarian, endometrial, vaginal, vulvar, gestational trophoblastic neoplasia, as well as patients who've got malignancy in pregnancy and those with familial gynecological cancers. So for cervical cancer, how do we work up these patients? First of all, we need a biopsy confirmed case. So you need to do a biopsy before you refer your patients. After you've confirmed that there is cancer of the cervix, you need to do baseline workup, which includes a full blood count, urea and electrolytes, liver function tests, a chest x-ray and ultrasound scan of the abdomen and pelvis. Ideally, we should do a pelvic MRI. However, we know that we live in a resource-limited setting. So that's why we've opted for chest x-ray and ultrasound scan. But if your patient can afford, by all means, let them have an MRI of the pelvis and then a CT scan of the chest and the abdomen. Which patients are ideal for surgery? For now, we are doing surgery for cases up to stage 1B2, which has been confirmed on imaging, not clinical staging. As we all know, imaging is more accurate in staging of cervical disease. So once you've got all these prerequisites, you refer your patients. We discuss these patients in the MDT and the tumor board, where we then come up with the definitive management. For ovarian cancer cases, once you suspect that your patient has got ovarian cancer, you need to do the baseline investigations again, your full blood count, your kidney function, your liver function. If your patient has got ascites, please do an acidic tap and send the fluid for cytology, biochemistry, as well as gene expert, as we've seen that some of these patients actually have got TB and not ovarian cancer. If your patient is less than 40 years, the tumor markers that you should do are LDH, alpha fetoprotein, and beta HCG. There's no role for CA125 in patients who are younger than 40. If your patient is above 40, the tumor marker that is ideal is CA125. If your patient has got symptoms, GIT symptoms, you should also include CEA. And for imaging, ideally, we need a CT scan of the chest, abdomen, and pelvis. However, if your patient does not have enough or adequate resources, you can opt for a chest x-ray and an expert ultrasound scan of the abdomen and pelvis, so preferably by a radiologist. You then refer your patient for MDT once you've met all these conditions, where we'll discuss the patient. Either they're offered neoadjuvant chemotherapy or primary surgery, or maybe chemoradiotherapy. After the definitive treatment, we then discuss the patient again in the tumor board to check for progress and if there's any need for additional intervention. For endometrial cancer patients, they need to undergo endometrial sampling. This can be done by the admitting firm again. Then the baseline biochemical tests, FBC, UND, LFT, CA125 as well. Please don't forget to do the cervical cancer screen. Sometimes we've been embarrassed when we think that a patient has got endometrial cancer and then you find out that they haven't been screened for cervical cancer. Turns out it's cervical cancer. And in terms of imaging, MRI of the pelvis is ideal, and then a CT scan of the abdomen and chest. If they cannot afford, again, you can opt for a chest X-ray and an expert ultrasound scan of the abdomen and pelvis. You then refer for the MDT, where the definitive management is discussed. And we know that the gold standard for management now is laparoscopic surgery, laparoscopic hysterectomy, and omentectomy. If your patient has got vulvar cancer, we encourage us to do an incisional biopsy. We've seen patients who've had excisional biopsies, and then it makes future management difficult. So do an incisional biopsy. If your patient has got multifocal disease, you can take them into theater and do vulvar mapping. For biochemistry results, you need a full blood count, kidney function, liver function. Don't forget to screen for syphilis, HIV as well, and the cervical cancer screening. Imaging, an expert ultrasound scan of the abdomen, pelvis, and groins. Do not forget the groins is needed. In case you suspect that they're positive groin nodes, you can then offer the patient advanced imaging, CT scan, or an MRI. They're then discussed in the MDT for definitive management. In case of GTN, again, we're going to do our baseline investigations, urinalysis, full blood count, liver function, kidney function. Please do your thyroid function test, as some will present with thyroid storm, quantitative beta HCG, and an HIV test. For imaging, an ultrasound scan of the abdomen and pelvis is adequate, as well as a chest X-ray. Then you refer, once you've got all this, to the Gyne Oncology team for scoring. If your patient presents with possible brain disease, you need to do a CT scan of the brain. If they are brain mets, you can consider doing an MRI of the spine as well. If you note again on the chest X-ray that there's metastasis to the lungs, you need to do a CT scan of the brain. So what can the Gyne Oncology team do? What can they do for us? They can facilitate MDT. They can formulate treatment plan for Gyne Oncology cases. Sometimes we refer patients back to the referring team if we feel that this is a low-risk patient and a general gynecologist can deal with the issue. We can also join the admitting team in theater if you consult prior to the surgery. As you've seen, the schedule is quite busy, so we cannot come to theater impromptu. Ideally, you can consult us prior to surgery and then invite us to theater when you're operating on the case. We can also do surgery for complex cases involving other teams, usually general surgeons, when necessary. What we cannot do is see inadequately worked up patients. So we've seen an increasing number of patients who are sent just when they're suspected for malignancy. Sometimes they're sent without a punch biopsy. This can be done by any referring team. Sometimes you've got confirmed cancer, but you don't have the investigations done. Like we've mentioned, the basic biochemical tests, the basic imaging. We cannot do much for these patients because we've already got a long waiting list. Patients who need stabilization, for example, transfusion, or they need a chest drain, this can be done by the admitting team as well. And unfortunately, we are not able to come for elective theater cases that have not been discussed in the MDT or that have not been consulted prior to theater. So when in doubt, what can you do? You can send consults for adequately worked up patients. You can do this before our grand round, which is done on Fridays. So you can work up your patients like we've already discussed, do the baseline investigations, write a consult. The referring team can ask their registrar to present the case, but if not, the Gyne Oncology registrar can attend to this. So what challenges have we been facing as the Gyne Oncology team? We've got a long waiting list of patients who need surgery. Right now, we've got almost 100 patients who await surgery. So we need help with offloading some of these 9 gynecological oncology cases. We also, unfortunately, do not have a dedicated ICU or HDU bed. So this places a challenge, especially when we've got cases like ovarian cancer that need long surgery. We've also faced shortages with blood products. And because of the staffing shortages in theater and the demoralized staff, we've not had adequate theater time. Like mentioned in Emily's presentation, chemotherapy drugs are always a challenge. Most of our patients are financially challenged. Our radiotherapy machines as well are not reliable. And there's not been enough interest in the subject. So we believe if we build up an interest for the subject, we can have better outcomes for our patients. What progress have we made thus far? We now have an MDT that's held fortnightly. And for those who want to join us, we now have CME points, 3 CME points for each meeting. We now have a chemotherapy clinic. The Cancer Care Support Unit has offered to support some of our patients who face financial challenges by providing chemotherapy drugs. Unfortunately, they also provide support for all cancer patients, not just gynae patients. So they can only take 10 patients at a time. So not all our patients are catered for. We've also come up with a prospective data collection tool, as Emily already mentioned. We'll be collecting information, not just for GTN cases, but for all gynae onco cases. And we also now have a weekly colposcopy clinic. So what's our take-home message? The gynae oncology team is here to promote evidence-based medicine in a multidisciplinary team setting. It's not about victimization. We're here to help and work together with the general gynecologists. So please feel free to consult at any time. We're happy to help. And as long as the necessary expertise is available, cancer patients may be managed in any team. So usually you just need to consult when you're in doubt or you feel you cannot manage the patient. Thank you for your time and for listening to this presentation.
Thank you very much, Emily, Yemu, for taking us through what is to be expected when we are sending patients through to the gyne-oncology team. As already said, we do have challenges with some patients who are referred when they are inadequately prepared, or the workload is a lot. So we would like to emphasize that may we listen to what Yemu has been telling us and improve the outcomes for our patients. So I'm going to open this time for discussions. At the moment, I don't see any raised hands. Neither do I see any questions in the chat box or in the question and answer segment. So as people are thinking up questions or what they want to say, I may give this time to our resident gyne-oncologist, Dr. Guja, if he's got things that he wants to emphasize or to highlight.
Thanks very much, Rumbi. I think at the moment I don't have. I think Yemu has kind of like discussed the challenges that we are facing. But I think what was happening now, we're seeing patients in the outpatients are just seen in the casualty department, cervical mass, then to the gyne-oncology team. No biopsy done, not even a single investigation done, or consulted for patients suspected sent to the outpatient clinic. They got a pelvic abdominal mass, so there's not even a single investigation done. So I think we need help with all the referring teams. That I think our role is maybe to formulate the treatment plan, but not necessarily to do all the punch biopsies, order all the blood. I think that can be done by the referring team. So when the patients then come to the outpatients, our role then should be to facilitate their discussion in the MDT and then formulate a treatment plan in the MDT. So we need, because the unit is very busy, so we need help by all the referring teams to make sure that patients are properly worked up. We can order some of the investigations if we feel that, but we feel that there's need to refer patients after basic investigations have been done. So I think what we're going to do next week is we're going to kind of like circulate a form to all the teams, which they can help just by filling and put all the necessary information that we need for the patient to be discussed in the tumor board. But we are very happy to facilitate. And I think that the take-home message was we're not only like a fact finding or victimizing people. I think what we just want is patients to be discussed in MDT. There's clear evidence that will improve outcomes. But we appreciate that there are people who have got the expertise, and if a team is happy managing a patient, I think they can go ahead. But we just encourage that probably it's better for the patient to be discussed in the MDT. Because what then tends to happen at times is that the case is managed, and then the oncology, radiation oncologists then refer the patient back to the MDT. And so just by avoiding that, I think people should feel free to have their cases discussed in the MDT. It's not a must, just an encouragement that we are making.
Thank you very much for that, Dr. Guja. In the chat box, we have a question from Dr. Dube, who is asking, is there a plan to expedite surgical interventions? I see you have a lot of patients on the waiting list. We are having challenges which are beyond us in terms of theater staff and also in terms of anesthetic assistance. So it is quite a challenge. I'll leave this question to Dr. Guja to respond.
Thanks a lot, Rumbi. So what we have done of late, I think for the past month or so, we've been having theater lists every week, but the challenge is that there's no motivation in the theater staff. So what we've started doing is we buy lunch for all the staff, the anesthetists, in the theater nurses, and they then allow us to operate until 4 or 5 p.m. So that is happened about, so kind of like thinking outside the box. And then what we are also looking for is, we spoke to Higher Life to see if they can't kind of like support a gyne oncology, a dedicated gyne oncology theater, maybe by paying the nurses work there some extra money, the anesthetists, so that we can have regular lists. I think what we basically need is a 1.5, like a full day list and a half day list every week. So we have started kind of like thinking outside the box to say, how can we get more theater time? So far, I think by providing lunch, we've managed to operate up to 5 p.m. for the past 2 to 3 weeks. So we're hoping that at some point, Higher Life will come on board, and with a better incentive for the nurses and anesthetists, we'll be able to operate longer and allow us to clear the backlog that we have.
Okay, thank you for that. Just to note that this incentive is actually coming from Dr. Guja's personal funds. He's the one who's footing the lunch for these motivations. We are welcome to people who would also want to assist as we await any formal donations for other people. We would be grateful for any other assistance that we can get. I do not see any other questions. Since there are no other questions, we've got a bit of time. We can include it into the lunch time that we have, since our lunch time was a bit short. So before we go to lunch, our sponsors from New Avocash have got a presentation that they want to give to us. So I'll leave this time to the sponsors.
If Vincent can share the screen. Thank you. Good afternoon, everyone. My name is Melody Mvundura. Can you hear me?
Loud and clear.
Okay, good. So I'm the medical representative of New Avocash under Innovatus Pharmaceuticals. So today I'll be presenting the soothing analgesic in relation to a disease called endometriosis. Next slide, please. So endometriosis affects an estimated 1 in 10 women during their reproductive age. So we are talking about 15 to 49 years of age, and approximately 176 million women in the world do have endometriosis. So this disease is considered a debilitating condition in most women due to its inflammation and pain. However, NSAIDs are recommended by guidelines for the management of such pain. Next slide, please. As new Avakash, we have something that is more potent for these women, and we have brought into our markets etoflam. The main ingredient is etoricoxib. It comes in the 60, 90, and 120 milligram tablets. The good thing about this molecule is it has pain control that starts from 24 minutes and lasts up to 24 hours. Next slide, please. So what are the indications for etoflam? Etoflam in this gynecological setting is indicated for your patients with endometriosis, or your patients who have post-op pain, or those whom you want to wean off from opioids and you don't want that addictive effect of the opioids, so you can use etoflam. You can use it for your patients with primary dysmenorrhea, and also even dental pain, gouty arthritis, or any other acute or chronic pain. Etoricoxib is considered a highly selective COX-2 inhibitor, which means it has no effect on the GIT effect. It has 100% bioavailability. It stays in the system for 24 hours. And as I have mentioned before, it has got a rapid onset of action, which starts approximately from 24 minutes, which we are actually looking forward for a patient to have something that has faster onset of relief of pain. The good thing about our etoflam, it has a long half-life and it's convenient for one's daily regimen. So it's only taken once a day. The good thing about it, it has less side effects and it's well tolerated across the globe. So, and etoflam has also other indications. So we are looking at endometriosis, we're looking at inflammation and pain. So it improves the pain control and also lessens the inflammation activity. And also it has better symptomatic pain relief when compared to other traditional NSAIDs, that's our non-steroidal anti-inflammatory drugs on the market. It has lower rates of discontinuation due to its GI adverse effects. And also it has, the only thing that you need to take note, it has comparable cardiovascular risks with traditional non-steroidal anti-inflammatory drugs. So what is our take-home message? So please note that etoflam is a highly selective COX-2, which doesn't touch on our GIT, so it's safe for our patients for GIT effects. Dosage therapy for endometriosis, we recommend the 90 to 120 milligram for your patients. And the good thing, etoflam has a faster onset of action in comparison with other NSAIDs on the market. So also it has a longer half-life, which is a 24-hour half-life. So meaning it stays longer in the system. So you don't need to titrate doses for your patients when they take the 90 and the 120 milligram. So I will emphasize, we have seasoned as new Avakash, we have seasoned the market with etoflam, widely available in all the pharmaceutical industries or the pharmacies in Harare and outside Harare. It comes in the 60, 90, and 120 milligram. Pain control starts from 24 minutes and lasts up to 24 hours. So this product is marketed by Innovata Pharmaceuticals and in conjunction with new Avakash. So thank you very much. And we are hoping that you prescribe this molecule for your patients, whether with endometriosis, primary dysmenorrhea, or post-operative pain. Thank you so much.
Thank you, new Avakash, for that presentation. Do we have any questions for our sponsors? So if there are no questions, we can Do you have another presentation?
Yes, they have another presentation. Okay. That's for 5 minutes before break for lunch.
All right, it's okay. You can proceed.
Good afternoon. Can you hear me?
Yes, we can. Please proceed.
Okay. Thank you. Good afternoon, ladies and gentlemen. My name is Joalyn Chanyanyiwa from New Avakash. I'm going to present to you our project, which is called AvaFem. So AvaFem is a probiotic formulation, which is an aid in the treatment and management of genital urinary tract infections. So what are the benefits of AvaFem? Next slide, please. The benefits of AvaFem are that it helps to improve and maintain urinary tract and gastrointestinal health in women. It helps to prevent recurrent urinary tract infections in women. And also AvaFem provides antioxidants for the good maintenance of good health. Where is AvaFem indicated? Our AvaFem is indicated for co-prescription in patients suffering from recurrent vaginal infections. Next slide, please. What constitutes our AvaFem and makes it unique? So each capsule of AvaFem contains 7 billion colony-forming units of lactobacillus strains that works effectively in maintaining an acidic pH that is between 3.8 and 4.4 that effectively eliminates pathogenic bacteria and yeasts, which are the Candida and E. coli commonly. Each capsule of our AvaFem also contains 500 milligrams of cranberry fruit juice powder and 100 milligrams of D-mannose that works effectively in eliminating urinary tract infections. The dosage of our AvaFem is that your patient is to take 1 capsule orally before breakfast, and it is recommended to take AvaFem 2 to 3 hours before or after taking antibiotics. That is, if the patient is on any antibiotic medication. Our AvaFem for use in pregnancy. So for your patients who come in with urinary tract infections being pregnant, AvaFem is totally safe for them. Next slide, please. The unique features of our AvaFem are that it is made from premium quality documented strains of bacteria, which have been confirmed through DNA sequencing. The strains of AvaFem are acid and bioresistant, making our product more potent. The good thing about our AvaFem is that it is non-GMO, it is gluten and allergen free, and also suitable for use with the vegetarians. So for your patients who come in complaining of genital urinary tract infections, your pregnant patients who come in with infections, AvaFem is an aid that can help in treatment and prophylactic prevention of such infections. Your patients can get them in the pharmacies. The cost for a month's supply will range between $15 and $18. Thank you.
Thank you, New Avakash, for that presentation. Do we have any questions or comments for our sponsors? I don't see any raised hands. There are no questions in the question and answer, and I don't see any questions in the chat box. So I think our session ends here. My time is saying 2 o'clock. We reconvene at 2:30, where Dr. Michael Nyakura will be leading the next discussion. Thank you very much.
Good afternoon to you all. I hope you have enjoyed your lunch. We welcome to the afternoon session. We're going to have another exciting lineup of presentations scheduled for this afternoon. We would like to take this opportunity to thank all the presenters from the morning and the midday. Quite an exciting lineup of presentations that we had, starting with our keynote speakers from SA. Thank you so much for all the presentations that you gave us the first two sessions of the day. Thank you so much for all the participants who have joined us for these presentations. Moving on, we're going to, by the way, I'm Dr. Nyakura, obstetrician and gynecologist, provincial mentor for Matabele North. I'm based at Victoria Falls Hospital. The afternoon session is another exciting lineup that we have scheduled for you, which should keep us glued onto our screens and reduce the risk of falling to the effects of the parasympathetic system. We have a number of presentations that are combined in the community, national, and global health section of our presentation. Our first presenter is Dr. Gororo. Dr. Gororo is an obstetrician and gynecologist based at Banda Provincial Hospital. He's a young specialist with special interest in cervical cancer screening in low resource settings. He's a consultant obstetrician and gynecologist for Matabele and North Province. Dr. Gororo, just please start sharing your presentation. He's going to be talking to us on OBG practice in the province, the challenges and controversies in patient care. Dr. Gororo, over to you. We can see your screen, Doc, but we can't hear you yet. You need to unmute yourself.
All right, can you hear me now?
Now we can hear you, thank you. Please go ahead.
All right. All
and
right,
yeah, go to screen sharing.
Okay, I'm on screen sharing. You can now see my slides, right?
Sure. Now we are on slideshow. Thank you.
Oh, all right, thank you very much. Thank you for the wonderful introduction, Dr. Nyakura. As Dr. Nyakura has highlighted, I'm Dr. Gororo, consultant obstetrician and gynecologist for Mat South Province, currently stationed at Banda Provincial Hospital. My presentation is not necessarily going to be an academic presentation, but rather just sharing my own personal experiences when I moved to the province, particularly issues that has to do with the challenges that comes working in the province, as well as some controversies or some controversial issues that comes about in the care of patients. Just probably as a background, I finished my senior registrar in November 2019, and I automatically joined Mat South Province in December 2019. And I was the first specialist actually to be resident within the province. Prior to my coming to Mat South Province, there were other specialists who showed interest, but none of them really took the post. All of those who took the post did not necessarily came to be resident, but rather got seconded in other hospitals that are outside the province. And probably the decision for me to move to South Province was not necessarily something that I had planned way before in that I was going to go to South Province, but it was just a sudden decision that I make after a conversation that I had with one of the junior consultants that I was working under at that time, who give me an idea that probably moving out of Central Hospital may be a good experience. And I remember the same day I actually contacted the provincial medical director. That evening I was already drafting the application letter, and within 2 weeks or so, I was already on my way to South Province. So what are my responsibilities as a specialist? Responsibilities at the station that I'm currently under, that is the provincial hospital, which include conducting specialist clinics, conducting surgical operations, teaching, and because of the nature of the grade that you get when you become a specialist, you can't run away from administrative issues. Though probably when I moved to the province initially, I had the mindset that I'm just going to concentrate on clinical issues. I'm not much interested in hospital administration, but you realize that when you are there, a lot of issues may circulate around you, and your decisions becomes very important. So at the end of the day, you realize that all of a sudden you have to mature in terms of administrative issues. Then I also have responsibilities at provincial level. At provincial level, I report to the PMT, and I work in collaboration with the provincial maternal and child health officer, the provincial reproductive health officer, and in certain circumstances with supporting partners as well. And our main activities are to do with maternal and child health issues, which include conducting perinatal audit meeting and making sure that they are conducted both for the province and also for the district. So we have that mandate to make sure that the districts are conducting perinatal audit meetings, and the perinatal audit meetings, when they have been conducted, they have to be sent to me as well as to the PMT and to the PINCHO. And here and there, we are also supposed to support the district in terms of conducting the meetings themselves. So oftentimes we find ourselves actually going to the district to support them when they perform their perinatal audit meetings. Here and there, we also do standalone maternal audit meeting, not necessarily a full perinatal audit meeting, but just auditing maternal dates that would have happened in various districts. We also conduct specialist clinics in various districts. Then also do support and supervision as well as mentorship. So when I moved then to the province, I suddenly realized that there are some challenges that are particularly unique to being in the province, probably things that we did not experience when we were at the central hospital. So these challenges, I tried to group them to say the challenges that has to do with the station at which I'm working, that is the provincial hospital, and the challenges that have to do with things at provincial level. One of the first challenges that I faced when I moved to the province at GPH is to realize that probably 80% of the nursing staff that we were working with, most of them, they've trained in district hospitals. They've never worked in central hospitals. So they have never worked with specialists before. So oftentimes the challenge was, which patient should they call you to see? Which patient should they call the GMO? So one of the challenges was initially, I remember the first week is you'll be called at night just because there's a patient who come in labor. There are no other issues. So they think now that there's a obstetrician, you're supposed to attend every patient who is coming from home. So it took time to really establish that in which circumstances should you call the specialist, which circumstances should you call the GMO, and also to establish that ideally under normal circumstances they should call the GMO first, unless there is a significant issue that warrants that the specialist come immediately, or in cases of emergency. And often that communication was not taken well, because you tell the nurses that please call the GMO first. Then they have an emergency, they can't get hold of the GMO, then they are now afraid of calling you as well. So the next thing they say, the specialist says, you must not call me. So that's one of the challenges that we faced initially. Then there was also issue to do with space. For those who have been at Rwanda Provincial Hospital, you understand that the facilities we are currently used were meant for a district hospital. I know that currently there are plans underway to construct the actual provincial hospital. So that created a challenge in terms of availability of space now that they are specialists. Oftentimes you realize that we do not have space to conduct a clinic. So you go to OPD, you want to conduct your clinic, all the rooms are occupied. So you end up moving the people that are using your room, they shift their things, you get in to do your clinic, then afterwards they have to come back. The same thing was also happening even in the antenatal clinic. You realize that there was only one room that the nurses were used for screening patients, and unlike probably the situation in Central Hospital, whereby patients came early in the morning for antenatal clinic, then they get screened, so that when the doctor comes, all the patients have been screened already. They've selected which patients the doctor see, which patients are for the sister. Here probably the patient comes in the antenatal clinic throughout the day. So you go to the antenatal clinic, but probably there's no good space for you to actually see the patient. So those are some of the challenges that we're facing. And soon after I just moved in, there was then the issue of COVID, which poses a significant challenge, because initially, I think this is what happens in most places, that we're kind of reactive to what was happening in terms of managing COVID patients. Because of the space as well, we do not really have a particular area that we could designate for COVID patients. And initially, we were very skeptical in terms of using our theater for operating COVID positive patients, because we had only one functional theater. And we had a challenge as well with a lot of staff that were testing COVID positive. It really left us with the skeletal staff on ground. Then the other challenge, I guess this may be quite true for everywhere else in government service. There's significant depletion of experienced workforce. To me particularly, this created a problem, because when I moved in, I had kind of created a firm. I had doctors that had interest in doing obstetrics that joined the firm. So the workload was kind of easy, because I was training them and they were quite competent. But each time and again, we have someone who is now experienced, who can now do quite advanced things. Then the next thing, the person is now leaving for greener pastures, and probably are working alone again. So that's one of the challenges. Probably this is an ongoing challenge. We also have issues with availability of laboratory and radiological services. This is quite a significant issue that affects both service in government and in private. Probably the investigations that you can easily do is mostly an FBC. That's the only test that you can comfortably do and probably get results in time. Any other test that you can think of, often it takes days to get results, which often becomes difficult in terms of decision making in those cases that you want to see results as urgent as possible. We also have challenges in terms of radiological services, particularly as much as ultrasound services are concerned. Currently at the provincial hospital, we only have one radiographer. I know the fetal medicine guys have been doing extensive work in terms of training midwives and doctors to conduct basic ultrasound scan. But one of the challenges that we face in reality on ground here is people are living probably at a faster rate than they have been trained. So we have patients going, midwives going for training. Then within 2 months or so, we are told that all the midwives that we trained for the ultrasound scan, they have left, and you are back to square one. And in terms of capacity, the radiographer alone cannot scan. Even with my assistance, we are not able to offer ultrasound scan services to all the patients that are coming for our antenatal clinics. Even if I understand we recently received a new ultrasound scan machine, I think that will make the total number of ultrasound scan machines we have in the hospital 3. So, but the people who operate the scans, that's the way the challenge comes in. Then we also have challenges to do with administration of clinics. This one has been quite a challenge, and at one point we just have to learn to adopt and work with the way situation was. The main challenge was, if you understand the nature of North South as a province, you realize it's mostly a rural province. Most of the places are rural. And even Rwanda itself, the town that I work in, it's a very, very small town. And probably 80% of our clients are actually rural clients. So now the challenge comes with the issue of booking in clinics so that you kind of have a control in terms of the number of patients that can attend the clinic. So you realize that our clients, they don't want to book for the clinic, even if the attending doctor would have recommended them to go to a certain particular area where the bookings are done. They tend not to book. So come the clinic day, we have
please not. You have 3 minutes. You need to start winding up. Thank you.
Oh, okay. All right. Thank you very much. So that also give issues. All right. Let me probably move to the provincial level. So also a challenges at provincial level, which included loss of staff. Some of our hospitals within the province are operating without a doctor or a midwife. Also have issues of limited resources to support programs, especially things to do with mentorship and support and supervision. Then also the issue of phone consultations. This poses quite a significant challenge in terms of often how best should you approach situations whereby a cadre is calling pertaining a case that probably is critical, emergent, and often need emergence, an emergence operation, whether to make a judgment that the cadre should go in and operate at that level, or should they refer? If they refer, would the patient make it? So that's one of the challenge in terms of decision making when you are dealing with phone consultation. And we also have issues with cervical cancer screening within the province, lack of coordination. We have various partners that are supporting cervical cancer screening, but it ends up seeming like each person is doing their own things with lack of coordination of all the parties that are involved. Then issues to do with the controversies in terms of patient care. One of the challenges is issue of investigation, which I mentioned before, and patients not affording to have investigations done in Bulawayo. So that poses a challenge, for example, with patients that suspect gynecological malignancy. Some you are not able to properly stage them or do proper pre-operative workup. And oftentimes when you refer out patients to UBH, they seem not to be interested in going and receiving services somewhere outside the town. So you are faced with a challenge whether should you go on and operate a patient without proper pre-operative workup? Should you send the patient should you send the patient knowing that the patient will not show up the next day? Okay. All right. I think there's someone who need to mute their PC. Then there's also issues of patients, for example, subfertility that cannot afford to do the investigation. Patient keeps on coming, you are writing the same investigation every time, but the patient cannot afford to go and do the investigation. Often you find yourself just prescribing probably clomiphene to say, well, you hope if it works, but probably it may not have been the right person to prescribe clomiphene. In particular example, we found patient that we prescribed clomiphene because she keeps on coming, but she can't afford the investigation. And she developed ovarian hyperstimulation after we prescribed the clomiphene. Then you ask yourself, probably, was it the right thing that I should just put this patient on clomiphene without investigation? The same applies even for patients with things like chronic pelvic pain. You are not able to do proper investigations prior to probably making a decision whether should you operate. So at times you end up just offering hysterectomy because that's what you are able to do. As well as the issue, I know this may be an issue of debate, issues with pre-malignant conditions of the cervix, particularly in younger patients, knowing that you may not be able to do follow-up for this patient. She's a young patient, tested positive, HIV negative, but probably if that's the only time you are going to see her, even if you say you will repeat the VIAC after 6 months, she may not show up. Should you go on and do a leap on a 25-year-old who's VIAC positive and HIV negative? Should you let her go knowing that she may not coming back? Then also issues with patients, particularly with gestational trophoblastic. This is quite a significant challenge. Often patients, we are not able to do beta HCG. The lab here does not offer the investigation, and the only place it can be done is Bulawayo. The patient is not able to go to Bulawayo to do the test, particularly during follow-up. So it becomes a challenge to see whether is the patient responding to the suction and curative that you did. We had one patient who had probably choriocarcinoma and we had started on methotrexate, but she was not able to do the beta HCG. Neither was he able to do even follow-up investigations like urea and electrolytes or even liver function tests. So it was a challenge. How should you follow? Should you give the next dose of methotrexate without even just checking the end organs? Should you give the next dose without doing a beta HCG? How many doses are you then going to give? So those are some of the challenges. The same as well for making decisions in obstetric patients with hypertensive disorder. So this gives a challenge in terms of whatever you are going to do. You know, the opinion of the next person may be different. So your management will always be controversial. Not that you don't know the right thing to do, but the support structures are not there so that you can do the right thing. So I just thought of this statement that whatever I done, was it right or wrong? So possibly at the end of the day, we are judged based on outcome. Thank you very much, Dr. Nakura. I think this is the end of my presentation.
Thank you so much, Dr. Goloro, for the nice presentation. I would like to request that all participants, you can just post your questions into the chat box. And those that want to ask further questions can always do that after all the presentations in this particular session. Our next presenter is Professor Mjanja. He's a consultant, is a lecturer at the University of Zimbabwe, and he's going to be talking to us on the updated WHO guidelines for MPDSR implementation. Prof. Mjanja, I'll give you the floor. You can start sharing your slides. If you get to your screen, you'll see what is written share screen, and you click on that and you can start sharing your slides.
It's updated. Okay, Dr. Nyakura, I'm finding the presentation.
Okay, that's okay.
It's in my document.
If you are still having challenges, Prof, I can share the screen for you.
It's coming up, I think.
Okay.
Can you see it now?
Not yet. Now it's coming up.
Okay.
We can see it now. So you can click on slide share.
Okay, so that's okay now. Can you see it?
We can see it, but it's still in the, it's not yet in the slide view. So you need to click where it says slide, share slide.
It is on slideshow.
Oh, it is?
Yeah, it is.
Yes. All right. Yeah, sure. Please go ahead, Prof.
Okay. Okay, this afternoon I'm going to talk about MPDSR and where we should be going in terms of maternal and perinatal death surveillance and response. And Dr. Gondongwe gave the apologies. We prepared the presentation, but she had to go to an emergency. So the outline of this presentation is that I will talk about the background briefly, review the current status of MPDSR in Zimbabwe, and then introduce the updated materials which have been created by the World Health Organization, and then suggest how to move forward on MPDSR. So the background to MPDSR, and what is it? It's an audit of maternal and perinatal mortalities in order to reduce or eliminate preventable deaths. And the activity in this area is targeting, obviously, the next goals of the United Nations, such as the 2030 goal of sustainable development. The history is that maternal mortality meetings were being held in various countries since 1973. The terminology moved to what they called maternal death reviews, and then eventually maternal and perinatal death review. But the World Health Organization was very keen that surveillance should be part of MPDSR. Surveillance meaning counting the deaths and the perinatal deaths. And then they emphasized the response as well, because perhaps people were doing audit, but were not checking to see whether the recommendations were being acted upon. So that's why those last two were added. Firstly, to make sure that we can count the events, whether these were maternal deaths or perinatal deaths, accurately, and secondly, to check the response to the activity. So the evolution of MPDSR started in 2004 when the World Health Organization wrote up a technical guide called Beyond the Numbers. And this remained the standard for 9 years until the next document was published, and it was called Maternal Death Surveillance and Response, Technical Guidance Information for Action to Prevent Maternal Deaths. Later, it was seen that we had forgotten about the babies. And so another document came up. It was called Making Every Baby Count. And this was an audit and review document for stillbirth and neonatal deaths. It came out in 2016. In 2012, the ICD had changed some of its definitions for maternal deaths and created a new classification called ICD-MM. And I will tell you later in this presentation where it fits in and where does perinatal mortality fit in ICD. It's called ICD-PM. And then the latest document is what I will present to you later. This is the latest from 2021, which introduces the materials which should be used for implementation. This is the document called Beyond the Numbers from 2004. And this cycle, so-called audit cycle, which I think most people are now aware of, first came out in that document in 2004. And starting at the top left corner, there is identification of maternal deaths. You then collect the information which has been written up about the death of the woman. Then you complete the forms that are required, you discuss the case and you make recommendations. And following that, you then check whether the recommendations have been put into place and what has been the response to the recommendations or the implementation of the recommendations. Another document, this was the most advanced technical guidance, which was produced in 2016. Making Every Baby Count, ICD-MM, ICD-PM, and the latest document from 2021, materials to support implementation of MPDSR. So you might be surprised that we have had MPDSR in Zimbabwe for 50 years. When I was in medical school in 1973, at Harare Hospital, they were already making records. They were already recording maternal deaths for discussion, and the meetings that were being held were called maternal mortality meetings. But the assessments of such activities came much later. Starting in 2014, a report by the Health Transition Fund into the implementation of MPDSR in district hospitals and facilities. Later in 2017, there was another assessment which showed that there was a high political will for the process of MPDSR, but that there were certain challenges which were being faced by the districts, such as the variable implementation at district hospital level. So some district hospitals were doing MPDSR and others were not. There were no standardized forms for collecting the data. This wasn't entirely true. I will show you guidelines which were published by the Ministry of Health, but it is true that at one time when the deputy director then, Ms. Yandoro, went around the country looking for the places where the information was being written up, she found 6 different types of forms, some which were being made by individual district hospitals, in addition to the notification form, which the ministry demanded every clinic, every district to send to headquarters. So about 5 years ago, the ministry created a national MPDSR committee, which is chaired by the permanent secretary. There is good representation of stakeholders. So the committee has obstetricians, pediatricians, anesthetists, community representatives, representatives of the partners, PMDs, and clinicians and midwives. It is a 3-year term of office. So the current one resumed meetings in October 2021, but there had not been too much activity then in 2020 and 2021 because of the COVID outbreak. This guideline was written up in response to the fact that Zimbabwe didn't have guidelines, and the World Health Organization had produced those guidelines in the technical guide of 2014. And Dr. Gungu of Bulawayo and this year of the Minister of Health and Dr. Makos, I think also Bulawayo, made a big contribution to this guideline, which actually has all the forms that were supposed to be used, the form for maternal death, for perinatal death, to fill those forms and to conduct audit in the prescribed manner. This guideline even had suggestions on how to form a committee and how the chairperson should hold the meeting, including the principle of no name, no blame, no shame. Unfortunately, there was not very good dissemination of that guideline, and the then successor to Ms. Shandoro, Dr. Makosa, tried very hard to disseminate the guideline, but I think there was variable access to this guideline, and we kept meeting people who had not seen it, even late into the 3rd year of the life of the National Committee. So Zimbabwe wasn't doing very well in recording the events and the minutes of the meetings. Facilities were not able to implement recommendations, especially blood, shortage of medicines, and there were the human factor issues which were identified, such as burnout, such as poor application to the issues at district level. So the new guideline now we have it has become very, it is set down, it is so comprehensive that it sets out in detail what you should do for MPDSR, including definitions of conditions, how to get started at the facility level, assessing the current situation, setting up a steering committee, determining operating procedures and tasks, how to identify the cases, collect information, etc., etc. It even has module number 10, overcoming the blame culture of MPDSR. I will send a copy of this document to the ZSOG so that they can send it around. This part is what you should read in the technical guide. Of course, most districts and provinces are already doing most of these. It's just that we, for example, we're a bit lax in writing up the minutes, and there were various other issues that we were not attending to. But there isn't any district hospital which has not been doing part of this. This document by MSHIP and USAID was one of the activities that reviewed MPDSR in Zimbabwe. So what did we do well in the past 5 or 6 years? We disseminated the concept of audit. We established provincial audit as an important activity. We created a national MPDSR committee, and there were annual reports. So Dr. Makwasa did a very good job for 4 or 5 years. There was always an annual report to read. What did we not do well? Well, we didn't monitor district level implementation of MPDSR very well. And I'm saying this because we don't have the documents to prove it. Documentation of processes was poor. So if you have a meeting and you don't write up the minutes, the attitude of the head office and other people is that there was no meeting. And although we tried very hard to impress upon people to write the minutes, they either wrote them and forgot to send them to the committee or didn't write minutes. We didn't monitor the implementation and impact of the recommendations. And we could not foresee COVID-19, of course, but it means that we need to set up a resilient system which is not affected by such things. So we have to restore pre-COVID-19 implementation. We have to strengthen the district level MPDSR and strengthen the provincial MPDSR. In other words, we make provincial MPDSR the main activity for audit. In other words, we get closer to the district hospitals, inverting the pyramid of activity. Because in terms of publication and documentation of the process, if it's not happening in Mutasa, it's probably not happening anywhere else. That is the attitude of people who come to assess whether you're doing things correctly or not. And I think the National Committee perhaps should concentrate on collecting and analyzing the data from provincial reports and attending provincial health team meetings. The Provincial MPDSR Committee should be established as per WHO template and should collect reports from district hospitals, approximately 1 per month. The idea is that every district hospital must do a report per month. If they are doing so well that they've not had any maternal deaths during that month, then they should do a near miss, they should review a near miss. But they should send 12 reports at the end of the year. And those reports go to the Provincial MPDSR Committee, so that the Provincial MPDSR Committee are mainly to join and support district MPDSR meetings and send reports to the National Committee, roughly 24 per year, so every quarter. So there's much more emphasis on collecting the information, analyzing it, and publishing the reports. By publish, I mean send them to the next authority. I'm just going to finish this presentation by giving an example of what we should do with some of the findings of MPDSR. So what we found in the past year or two is that preventable deaths from lack of anesthesia are quite common. And we see time and time again women who have died from severe preeclampsia and eclampsia because either there's no anesthetic service at the district hospital or the people who are there are not confident enough to perform anesthesia for obstetric labor, for sepsis, for fetal distress. And unfortunately, this is anecdotal, it's not scientific. There is a rise, for example, in Harare of HIE and cerebral palsy. So you even get these delays in urban areas and in tertiary hospitals. So lack of anesthetic services from the point of view of the MPDSR.
Sorry, Prof. Yeah, about 1 minute to wind up.
Okay. So if we talk of the doctors, there are not enough of them, not many with sufficient training. and unclear what they are covered for and by whom. Those are the district hospital doctors whom we expect to perform anesthesia. Nurse anesthetists experience even more problems. All of the above plus there's a unique chain of command. There are unique chain of command issues, unique conditions of service such as duty roster, what they're doing, their downtime, lack of facility establishment. So we don't even know how many nurse anesthetists should be present at any district hospital. And there's overreaction to isolated events by authorities, by which I mean a nurse anesthetist puts the patient to sleep and there's an accident or a problem, and then people say all nurse anesthetists should now be stopped from doing certain things. So what I have suggested with Dr. Gondongo is that we should write a recommendation to the Ministry of Health, especially about nurse anesthetists, trying to improve their conditions of service and their training and their retraining, because we are going to need them definitely up to 2030. I don't think that there will be a time before 2030 when we can say we don't need nurse anesthetists. That's just one of the issues coming from MPDS. I finished this presentation by showing you a slide of my class's graduation day in 1974. On the extreme left, you can see Mr. Makarao. And second from right, it's me. I used to be good looking, actually. And so this was my class from 1974. Thank you very much for your attention.
Thank you, Prof. Nice image of you in the younger days of your practice. Thank you for the presentation. I'm going to ask the participant to please hold on to your questions for the end of the session. For the sake of time, I'm going to quickly ask Dr. Rambanapas to start sharing his slides. Dr. Rambanapas is a consultant obstetrician and gynecologist based at United Bulawayo Hospitals. Sorry, Prof. I would request you end sharing your slide. Okay. So that Dr. Rambanapas can share his.
Okay.
Dr. Rambanapas is the acting clinical director at UBH. He has special interest in urogynecology and reproductive medicine. He is going to give us a talk on VVF, the UBH experience. Dr. Rambanapas, please take over the floor.
Okay, thank you very much, Dr. Nyakura. I've decided to share with you some of the work that we have been doing in urogynecology. You will notice that I will talk about what we've been doing in 2021 and in 2022. This is because prior to 2021, we did not have a database for these patients that we are operating on. We started doing fistula repairs in 2013, but prior to 2021, we're not keeping records. So in 2021, we decided, okay, let's have a database so that we can follow up these patients that we are operating on. Even though there are references here and there, this is not intended to be an academic presentation. Instead, it's just an outline of what we are doing and how we are doing it. So I'll start by giving you some of the statistics of the work that we did in 2021 and 2022. We could have done more were it not for the COVID challenges that we had, challenges in theater and the lockdowns and all that. But we managed to evaluate a total of 21 patients who had urogynecological issues. 12 of them ended up in theater with some operation of some sort. And of these 12, 8 actually had some kind of fistula. 6 of these fistulas were as a result of an obstetric cause, and one sustained a fistula post-hysterectomy. One was a fistula VVF due to trauma. Of the fistulas that we did, 3 were actually VVFs, 2 were ureterovaginal fistulas, 2 were ureterovaginal fistulas, and 1 was a cervical fistula. All the cases, bar 1, are currently happy, they are dry and they're okay. One of them only presented to us about a month ago when she started leaking again, 2 months post repair. I mean, our figures are too small. We can't really start going to town about the success rate and all that. So I'm going to focus this discussion on VVFs, vesicovaginal fistula. Just by way of definition, an obstetric fistula is a hole between the vagina, cervix, or uterus and the urological system, or rectum that is caused by prolonged obstructed labor, leaving a woman incontinent of urine or feces. This is quite a debilitating condition, which literally robs the patient of a social life. There are at least 3 million women worldwide that are moving around with untreated VVF. According to the WHO, you are looking at about between 50 and 100,000 women developing an obstetric fistula every year. And the vast majority of those patients are located in sub-Saharan Africa. When it comes to the pathophysiology, I think this is common knowledge. It's all about the three delays. WHO talks about the three Ds. We are basically saying that some kind of obstetric intervention is required, but for one reason or the other, it is not done on time. So what you then get is the bladder and the vagina are caught between the presenting part and the maternal bony pelvis, which results in field ischemia, pressure necrosis, the dead tissues then slough off, and you remain with the hole between the bladder and the vagina, which allows urine to leak uncontrollably. The typical fistula patient, we also see this in the patients that we are dealing with, is usually the typical patient is a young patient, a teenage mother usually. These patients, most of them come from the remote rural areas. Most of them are poor, they are uneducated, they are unemployed, and we also have a huge representation from the members of the apostolic sect. And if you look at all these factors here, they speak to putting the patient at a higher risk of having those 3 delays. Apart from the obstetric cause of fistula, we also have other causes that we are all aware of. You can have a fistula post-surgery because of cancer, your cervical cancer, colon cancer, radiotherapy. You can get congenital fistulas. You can also get trauma, which can be sexual, especially in the prepubertal girls, or trauma from any other cause. And then you can also get infections, particularly schistosomiasis. They can result in a fistula. So I'm going to discuss the principles that we are following at UBH, the approach that we have adopted for the patients that have got VVFs. What we are doing is we have said, okay, all those patients that are coming with VVFs, we see them as and when they come. There are no specific days. We've got 2 gynecologists, myself and Dr. Ondonga, who are interested in dealing with these patients. So we see them as and when they come, with the support from the rest of our team in the department. We try to do the operations at least 3 months after the injury. This allows necrotic tissue to slough away so that the fistula really defines itself. It also allows inflammation to die down. We do good pre-op assessment. This is very important. So we do examination in under anesthesia or examination in theater at least. We do a dye test if we are not too sure what is happening. Sometimes we do IVU. Rarely do we do cystoscopy for this patient. The idea of a good pre-op assessment is basically to fully characterize the problem, because sometimes you get a patient who is leaking, you think it's a fistula, meanwhile you're dealing with maybe urethral sphincter insufficiency. You want to see and get to know what type of fistula you're dealing with. Is it a urethrovaginal? Is it a ureterovaginal? Vesical, uterine? How many fistulas are there? How big are they? How much fibrosis do you have around the fistula? Because all these have implications in terms of what you're going to do in theater. You want to assess the patient for medical conditions. If they have HIV infection, is it well controlled? Is the viral load well suppressed? If they have diabetes mellitus, is it well controlled? Because these can affect the outcome of your repair. We try to schedule the operations on a less busy day because sometimes they really take a lot of time, especially if you are still learning. You want to ensure that there is availability of appropriate surgical instruments, and we are lucky. We have had support from UNFPA, who have provided us with 2 surgical sets for 2 Gyne sets that we use for our fistula. We try by all means to use the vaginal approach. There are several advantages for doing that. The only time when we go abdominal is when you are dealing with maybe a ureterovaginal fistula or vesical uterine, vesical cervical fistula, or if you have a very high fistula somewhere in the fornices, there it's very difficult to access that fistula from below. But by all means, we try to go vaginal. It is important when now in theater to have a very good exposure. So we operate most of our patients in Trendelenburg's position, which really highlights where the fistula is. We use a weighted speculum, and we also use labial sutures to make sure that the fistula is visualized. The lighting has to be very good. I always say never venture where you cannot see. We use hydro dissection. So before we start dissecting, we infiltrate normal saline, or we can use dilute adrenaline, 1 in 200,000. We infiltrate between the vagina and the bladder. This creates good dissection planes and also reduces blood loss during the operation. The next bit is to make an incision around the fistula. This incision should only be as deep as the vaginal mucosa. Don't go into the bladder. Then you do extensive dissection. The idea is to separate the bladder from the vagina. So this also gives you a full appreciation of the extent of the fistula. Because sometimes after pre-op, especially where there's a lot of fibrosis, you would think that the fistula is very small, but after dissecting and exposing the fistula, you'll be able to appreciate the full extent of the fistula. The other reason why you want to do extensive dissection is so that when you're now suturing the bladder, you'll be able to fully mobilize the bladder in such a way that you'll be able to suture without any tension. If you suture with tension, you are destined to fail. Then after dissecting, mobilizing the bladder, you want to identify the ureters. You catheterize them if it is necessary. We catheterize if they are very close to the edge of the fistula. If they are far away from the fistula and you know that you can suture without including the ureters in your sutures, then there's no need to catheterize them. Then you excise all fibrotic tissues around the bladder defect. So when the bladder defect, there will be this white tissue, which is fibrotic. You excise it so that you have a fresh edge, which will heal without problems. We use interrupted 2O absorbable suture on the bladder. We try to remain extra mucosa, because if your suture goes into the bladder cavity, you are increasing the risk of bladder stone formation. One layer on the bladder is usually enough, and you want to make sure that your closure.
Dr. Ramanabazi, you have 5 minutes to wind up. Thank you.
You want to make sure that your closure is watertight, and if you are not sure, you can do a bladder dye test before you have closed the vagina. Ensure that hemostasis is achieved. You don't want hematoma formation, which will lead to sepsis and threaten your repair. Then the vaginal mucosa is not really important. You can close it with Vicryl, either 2O or 1 Vicryl is still enough. Then you catheterize and inflate the balloon with not more than 10 mils. You don't want the bladder, the catheter balloon to put pressure on your repair. We take the vagina, remove the swab to the next day, put the patient on antibiotics, and we want to feed the patient as soon as possible. Post-op, there are 3 principles that we are looking at, apart from the other usual post-op examinations that we do. We want to make sure that the patient is drinking, want to make sure that the patient is draining, and we want to make sure that the patient is dry. Drinking is difficult for these patients because most of them would have learned that if they don't drink a lot of water, they don't wet themselves. So, but after repair, we want them to drink a lot of water, at least 5 liters in a day. This reduces the risk of catheter blockage and reduces the risk of stone formation. Draining, we leave our catheter in situ for an average of 2 weeks because you want the repair to heal without any tension. For us, a blocked catheter is an emergency, and those are the reasons why the catheter may block: tissue debris, blood clots, kinking, and a full urine bag. But what we've done at UBH, because our nurses sometimes can be very busy, we teach our patients immediately to empty their urine bag on their own. And then we want to make sure that the patient is dry, but there are causes of a wet bed. Urethral spillage, a leaking catheter, or sometimes you can have a new fistula formed during your operation, or if you didn't recognize a fistula, you repair one, meanwhile there are more than one, or the patient can be wet because of a failed repair. You will notice that our patients, after years, months of leaking, the bladder would have lost its capacity. So we do bladder training so that we regain that bladder capacity. We do this so that the trip back home is more comfortable. If you don't do bladder training, the patient will be stopping the bus every 15 minutes. So we leave the catheter in situ and we ask the patient to block, to clamp the catheter. Then they remove the clamp when there's the edge to void. By the end of the day, you should be able to hold the urine for at least 2 hours. Instructions upon discharge: we want the patients to avoid sexual intercourse for 3 months to allow the repair to heal. And if she is to fall pregnant, in the next pregnancy, she has to deliver by C-section. The complications of fistula surgery: you have stone formation, dyspareunia, reduced bladder capacity, especially where you have a huge fistula, we have significant loss of bladder tissue. You can also get vaginal stenosis, and you can get new fistula formation. We have a number of challenges that we are facing. One of them is lack of theater time. The user fees, now this is not so much of a problem for us because we've negotiated with management. Our patients are being exempted from paying. But you find that sometimes we also have challenges with sundries, and to ask these poor patients to buy even a pair of gloves is very difficult. We have few surgeons who are interested in fistula surgery, and then we also lack support to help the patient reintegrate into society. What we hope to do in future? We want to be able to do more. At UBH, we have capacity to do at least one per week. We want to be the center of excellence in obstetric fistula management. There is a theater that we're trying to build with the help of UNFPA at UBH. Once that opens up, then we can have more theater time. And then we hope other partners will come on board to assist with other aspects of care, issues of mental health. Most of these patients, some of these patients are actually depressed and have mental health issues which need to be addressed. Social issues. Remember, if a patient has been leaking for a long time, they are ostracized from society. How do we help them to reintegrate into society? We also worry about financial issues for the patient. Okay, I thank you. I hope I was on time.
Thank you so much for the presentation, Dr. Rambanapasi. Exciting news coming from UBH there. We really thank your team for taking this up and try and decentralize the management of obstetric fistulas from mainly Chinoyo Hospital now to involve even the Matabeleland region of our country. Thank you so much, and please keep this up and let's have more people join your team. I'm going to request Chipo Dembeza to start sharing your slides. Our next presentation is coming from Mrs. Chipo Dembeza. She's going to give us the lived experiences of obstetric fistula survivors in Zimbabwe. So this is like a continuation of Dr. Rambanapasi's presentation. Chipo Chimamise Odembeza obtained the BSc Nursing Sciences degree from the University of South Africa in 2005. In 2010, she obtained a Master of Public Health degree with the University of Zimbabwe. She went on to do a PhD in Public Health with the Africa University, and has completed the degree in December 2021. In her doctoral studies, she assessed experiences, quality of life, and health-seeking behavior of obstetric fistula survivors before and after the surgical repair, with the aim of improving case identification and linkage to care. Over to you, Chipo.
Thank you, Dr. Nyakura. May you please confirm if I'm audible?
Yes, we can hear you loud and clear.
Okay, thank you. So I'm going to present our study on lived experiences of obstetric fistula survivors in Zimbabwe. And this is going to be my presentation outline. I'm not going to dwell much on the introduction because fistula is explained by Dr. Rambanapasi. But the statement of the problem, due to inadequate documentation of experiences of women affected by obstetric fistula in Zimbabwe, there is little, if any, public health interventions to address these aspects of fistula survivors. Yet it is important to provide a comprehensive package of care to the affected women, as Dr. Rambanapasi has already alluded to. And according to the World Health Organization, this comprehensive package includes identification of cases, repair, rehabilitation, and reintegration into the community. So evidence is needed to inform decision makers on policy formulation for the fistula program in our country. This study aimed to explore experiences of obstetric fistula survivors in Zimbabwe, and specifically to assess social, emotional, psychological, economical, and physical experiences of the women before and after repair, and also to assess their health-seeking behaviors and their quality of life. hoping that this study is going to aid to scientific evidence, which is critical in fistula programming in the country. So it may lead to policy formulation to deliver a complete and comprehensive package of care. And also it contributes to the body of knowledge about the experiences and quality of life of obstetric fistula survivors in Zimbabwe. So our methodology. We conducted a longitudinal before and after study using both quantitative and qualitative methods, and we did purposive sampling of study participants from women who had come for fistula repair at Chinhoyi Provincial Hospital in Q4 of 2019. Data for assessing the quality of life were collected using the WHO Quality of Life Brief Questionnaire, using a semi-structured interview guide. Demographic data were cleaned and analyzed using the statistical package for social sciences, and scripts from the in-depth interviews were analyzed using in vivo 10 software for qualitative data. Quality of life data from the WHO Quality of Life Brief were analyzed using the associated SPSS syntax files, and a mean score below 40 in each domain denoted poor quality, 41 to 60 denoted moderate, and above 60 showed good quality of life. The paired t-test was used to compare the means of scores in pre-treatment and post-treatment phases, and a p-value of 0.05 or less was considered to be statistically significant. All ethical issues were observed, and confidentiality was maintained throughout the study. Coming to our results, a total of 26 women were recruited into the study with a median age of participants of 34 years and a median age at sexual debut of 18 years. But by age 24, 75% of our study participants had had their first pregnancy. 17 of the women had not had any surgeries or any attempts to repair their fistula problem. This table here shows characteristics of our study participants. And of note is that 15 participants stayed more than 10 kilometers from their nearest health facility. And 17 of the women had serious sores on their genitalia and their thighs due to urine. And 19 participants had their first pregnancy, 24 years or less. But also on a good note, 24 participants left the hospital with their fistula closed and dry, and a further 2 had their fistula closed, although they still had stress incontinence. Experiences of study participants before and after treatment. 22 participants got into labor and spent a minimum of 2 days laboring at home. 11 participants sought medical care for delivery only after noticing complications such as swelling of the body or even fitting at home. Participants cited that they had little or no power to decide whether to go to hospital or not. And all participants, even those who were not of the apostolic sects, first sought help from religious healers. On the physical consequences of living with obstetric fistula, the continuous wetness due to leakage of urine led to excoriations of the genitals and thighs. And some of the women reported frequent urinary tract infections. And all participants complained of persistent bed odor, which followed them wherever they were. But 6 months after successful surgical treatment of the fistula, the same participants expressed great improvement. Their sores had healed, the bed smell had ceased because now they were now continent. On the psychological and emotional consequences. All participants narrated psychological and emotional misery while living with the fistula problem. And most women recited long periods stretching up to years of mental torture. And of not one woman had lived 49 years with urinary incontinence due to obstetric fistula. Almost all of the women reported thinking that death was an easier option at some stage in their lives due to psychological trauma from the problem, and contemplated suicide at one point. This word tree here illustrates the psychological consequences of living with obstetric fistula, and we can actually deduce stories told by women like fistula problem. I was mentally tormented with fistula. I was tormented so much by this fistula. So you can actually tell stories, and you can actually, we did micro analysis of this data to trace the sources and the context of this word tree from the in vivo. On social consequences, 13 study participants reported negative consequences on marriage, with 7 of the participants having been divorced. Some were not officially divorced, but were in the marriages just for the convenience of it. Others were getting support from their spouses, but largely their in-laws did not support these marriages. This word cloud here represents the most frequently spoken words regarding social consequences of living with obstetric fistula. And the bigger the font of the word, the more frequently it was said by study participants. And again, on microanalysis, you can link the sources and in the context in which these words were spoken to. And you can actually come up with all stories also relating to the social consequences, like relatives were talked about by most participants, and relatives did not support the participants. And participants had to change their way of lives and limited activities due to this condition. You can actually tell stories from this word cloud. On the economic front, women who were previously engaged in public activities reported much disruption in productivity due to the occurrence of the fistula problem. And 6 months after treatment of the fistula, the economic aspect of their lives had not changed much. On health-seeking behaviors, most of the participants had not had any attempts on medical treatment of their obstetric fistula problem. But 19 participants reported seeking alternative types of treatment, which included faith healing, traditional healers, and herbal treatment. Coming to reasons for not seeking medical and surgical treatment, participants highlighted that they had a belief that it was their fate, like they were getting punishment from a supreme being for their wrongdoings and they deserved to suffer. Lack of knowledge of availability of repair services, powerlessness regarding decision-making, and lack of resources for those few who knew that this was a medical condition and can be repaired by medical, by surgery. They didn't have adequate resources. This table here shows us the scores from the WHO Quality of Life Brief 2. So it shows the quality of life of participants before and after surgery. And it's divided into 4 domains: the physical domain, psychological, social relationships, and environment, and also 2 standalone questions on the overall assessment of quality of life and the satisfaction with health status by study participants. And then of note is that before surgery, only the physical domain scored moderately, but all the others were scored poor quality of life. But after surgery, all domains rose to the good quality of life, and all these observations were statistically significant. This table here went further to analyze those facets which make up the domains. And we can see that although all domains rose to good quality, there are some facets which did not significantly improve, like in domain 1, dependence on medicinal substances and medical aids. And in domain 4, financial resources and opportunities for participation in recreation and leisure activities. These facets did not significantly improve. Our discussion. So in tandem with the general findings from the ZDHS, the median age at first sexual encounter was 18 years. Although this may be viewed—
5 minutes to wind up.
Thank you. Although this is a relatively mature age to start sexual activity as compared to findings from other studies, the majority of these women went on to become pregnant within a year after their first sexual encounter. And a quarter of the women got pregnant by age 18, and 3/4 by age 24, they were pregnant. It has been identified from literature that early age at first pregnancy increased the risk of developing obstetric fistula. Participants got blamed for developing fistula, and this is common findings in other studies. This thinking may result in low self-esteem and low self-worthiness to the fistula survivor and may aid to tendencies of suicide. Unlike developed countries where fistula has been eradicated, we noted that more than half of the participants developed obstetric fistula less than 5 years ago, with more than a third of the women having developed obstetric fistula in the last 12 months. This finding may be of concern to Ministry of Health policymakers because it is an indication of poor quality of or lack of access, as pointed out by some researchers. So in tandem with findings from a WHO study, in tandem with findings of our study, the WHO pointed out that obstetric fistula is partly a social and women's rights issue. As some of you have seen an article from Amnesty International in 2021, where they were holding up the ministry to increase care for obstetric fistula survivors. In that document, it is said that many African and Asian traditions, the decision to seek care for a woman lies with her relatives. But some authors argue that this viewpoint is mainly assumptions from researchers. They argue that in African religions, women are not treated differently, and they have the right to decide what to do. The high rating of quality of physical health after treatment pointed to the fact that indeed women living with obstetric fistula encounter challenges in their physical health. And the realization that they were now free from wetness and bed odor, together with the improvement in physical health, led participants to regain self-esteem and self-confidence. Participants reported improvements in sleep patterns, ability to concentrate and focus, which are all essential attributes required for good mental status. Participants laid, so in conclusion, we said the problem affected almost all aspects of participants' lives. These experiences, coupled with lack of support, led to perceptions of self-worthlessness, low esteem, and suicidal tendencies. Participants did not have adequate knowledge about obstetric fistula, and reasons for staying with the problem were as cited in a previous slide. Successful surgical treatment of the fistula problem offers relief from the consequences of obstetric fistula, and that most participants sought treatment of their fistula from faith and religious healers. So we recommend that information about obstetric fistula be disseminated to community leaders, religious leaders, and all stakeholders, and that women affected by obstetric fistula should be identified and repaired so as to improve their quality of life. And the ministry should publicize and disseminate information on the fistula repair program to help affected women understand that help is there and is available. And also to remove barriers to treatment of obstetric fistula to enable women who would have fallen through the cracks of the healthcare system and developed the fistula to access treatment freely. Thank you. Over to you, Dr. Nyakura.
Thank you so much, Jibo, for a brilliant presentation, highlighting the problems faced by the women who suffer from obstetric fistula. Thank you so much for that presentation. And we hope with the new setup being put up at the UBH, we should be able to have these women cared for. This brings us to the end of the academic session of the last session, which is community, national, and global health, which started with a presentation from Dr. Gororo on the challenges faced by the provincial OBS and Gyne teams, then followed by the presentation from Prof. Mjanja on the WHO updates on the MPDSR, and then Dr. Rambanapasi with the VVF at the UBH, and eventually Chipo gave us the last presentation. I would like to open the floor now to those who would like to ask any questions to all our presenters for the afternoon. I see Prof. Mjanja's hand is up. Please go ahead and give us your question. Prof. Mjanja.
It's not a question.
Please go ahead.
It's not a question, actually. I spoke to Dr. Makosa. I don't know if she's in if she's in the meeting, and I recommended that we should use the evidence from Dr. Rambanapasi and Dr. Dembeza's papers to formulate a recommendation to the Minister of Health about user fees for obstetric fistula repair. So it's good that Dr. Rambanapasi is now persuaded UBH to remove the user fees. But actually, this is a big problem at Pari, at Harare, and other provincial hospitals, because the fee in the tariff is $400. And I think it's a human rights issue. You cannot actually charge a woman that much for a problem which you were complicit with. In other words, the women end up with that fistula because the Minister of Health has lacked facilities to ensure safe delivery for every woman. And then when you have a policy of free maternity care, she comes back for repair and you want $400 from her. The administrators don't understand this, and I spent 2-3 years fighting with the people at Harare Hospital to reinstate fistula surgery at Harare Hospital, and I failed because the finance people said, it says here in the tariff she must pay for $400. So unless the permanent secretary writes a letter to all the hospitals, UBH will remain an exception, and women who go to other hospitals will still be demanded $400. So I I recommended to the scientific committee that we should write a recommendation backed by the evidence, a one-page recommendation, both for the anesthetists and for the fistula repair. So I leave it to the officers of the ZSOG to formulate with the right language for laying, at least if we send the recommendations, we've done our part. If they are not put into place, then that is beyond our capability to change policy. But I think just to look at this information, like what Chipo and Rabanapas had presented, and just go away and do nothing, I think it wouldn't be good for the society. Thank you,
Prof.
Yes.
Thank you so much, Prof. I think it's very important that you are raising a very important point there, which was clearly evident from Dr. Rambanapasi and Chipo's presentation, that the majority of these patients anyway are those who are coming from a poor social background. Definitely charging them that much may not be making any logic and would defeat all the purpose of trying to help these people who are in such a debilitating condition. Thank you so much for that contribution. There are a few comments that are in the chat box. The first one here is directed to Dr. Rambanapasi from Dr. Kanonge. Good work you are doing, Dr. Rambanapasi. Well done to your, well done. Do your patients pay for the treatment? I think that was answered in the presentation. The next comment comes from Prof. Munjanja as well. I'm so pleased that we have now young gynecologists in the country interested in fistula surgery. For a long time, we have relied on foreign specialists. We need more to join. Dr. Rambanapasi and Wondonga. Well done to the two of them. That's a comment as well. Then there's a comment from Dr. Dube. Well done, UBH. Great work indeed, life-changing. Dr. Mrewa Nema, congratulations indeed to the team for this great work. Very insightful, qualitative findings, worried about the quantitative element, validity of t-test given the small sample size and pervasive sampling. All the same, congratulations. I think that should be the last comment that we have here. Or we have a response from Dr. Makosa to Prof. Munjanja. I think, thank you for bringing this up. ZSOG will take up the subcommittee to the ministry, I'm sure, to try and have these procedures done without a charge. I don't see any other questions. If there are any other questions, please go ahead and post them in the chat box or even raise your hand. Prof, is that a new hand or is the old hand that is still up?
Okay, I'll drop it.
Okay, thank you. All right, so if there are no further questions, we'll go into the last part of our presentations. I would request Chipo to stop sharing your screen so that we can have the next presentation. So our next present, I will ask Prosper to please start sharing your presentation. Our next presentation is on wealthy and finance. I'm sure Mr. Matiashe wants us to make money. So Prosper Tafaza Matiashe is a qualified actuary by profession. He currently is the head of analytics and actuarial services at FBC Holdings Limited, a diversified financial services company in Zimbabwe. He is a fellow and council member of the Institute and Faculty of Actuaries UK, and also volunteers in marking and examining of IFOA exams. He is also a fellow of the Actuary Society of Zimbabwe. Prosper has deep experience in product development, pricing analytics, and evaluations of financial services products. Prosper actively participates in national projects like mortality tables for Zimbabwe, insured lives, and compensation framework for macroeconomic loss of value pensions and policies. Prosper is an active investor across different markets. He's a farmer and also an Arsenal supporter. I hand over the floor to you, Prosper. Please educate us on wealth and finance.
Thank you very much, Doc. It's my pleasure to have this time to just share a few insights about wealth and finance. I've termed it wealth management for experts in general, because you will find that your profession has much deep expertise. There are other experts. You talk of the lawyers, the engineers, and our findings in various studies or just work that we normally do in financial services or banking is that sometimes, despite these professions being very well technical and qualified experts, they may not necessarily be very good with wealth management. So we want to go deep and just say within the shortest period of time, how best we can try and correct maybe some of the challenges that we've been seeing in the market. In general, we want to say, okay, so wealth, what is wealth? In general, you find that it's a plentiful supply of a particular desirable thing. But in general, we talk of valuable possessions or money, right? So if you have a abundant or plentiful supply of time, for example, it can be termed as wealth, right? But you find that in our normal way of doing things, or what we have typically then socialized, is that money is or valuable possessions are what we term wealth. So it might include personal property. It might include income-producing assets, right? You talk of real estate, stocks, bonds, businesses. So here, for example, why do you put that income-producing, right? You might have your first house where you are staying, right? Yes, we can argue that, well, you are saving on rent, you are giving peace of mind to your family, for example. But it's not, in plain terms, we can't say it's generating income, right? So if people want to be very strict about wealth, they will say, look, the house that you are staying is not necessarily part of your wealth, right? It's just a need that you have taken care of, but it's not generating that extra dollar, right? So it becomes worrying when I think your profession, even mine, engineers, lawyers, once we start making good money, we want to have 5 houses, not necessarily being rented, right? And they are not generating any income, right? So we then tend to debate, is it wealth if it's not generating any wealth, right? Stocks, we are going to go deep into stocks, explain what they do, the bonds, businesses. Some of you are running your own companies and practices. They generate income. So it becomes part of wealth. They can be monetary assets, keeping cash, for example, some short-term investments. If our economy was stable, you would find that there would be opportunities to invest for 6 months. You get it after it has ended, maybe 4 or 5%. You're just making your money sweat a little bit. Those are some of the things that we call monetary assets, right? It can include health and well-being, social, spiritual, physical. If you have time, for example, you are generally deemed wealth, because there can be someone who is a billionaire but does not necessarily have time, right? Some of us who work for companies, it has always been said that we are selling our time for a monthly income in a way. So again, time becomes a key variable that you find is very critical when talking about wealth, right? So what is the process, right? One of the key things that you will find is that you need to be able to generate cash flow to build wealth, right? You are not going to develop any wealth to talk of if you don't generate any income or cash flow. So you find that I think for most of us, we are already working, maybe employed, sometimes owning our own ventures, our own practices. So you then find that generating cash flow is not a problem, especially in terms of just income. Usually the problem comes from the issue of expenses, where you are earning 10,000 USD or 5,000 USD per month, but you are equally spending the same amount per month, right? Or maybe 95% of that income. You then find that if you look after 5 years, you might not necessarily have added to your wealth. Or even when you retire, a lot of people have realized when they retire that they are very poor, right? But when you look at their profession, their work, they are well renowned, they've done marvelous things, but in terms of building wealth, they didn't. It's coming from cash flow. We are going to go a bit deeper on that one. You need to build and then grow the wealth, right? Once you have cash flow, how do you make the next dollar to then build another 10 cents, right? There's a certain small book called The Richest Men in Babylon. It says gold coins should then grow or give birth to silver coins, for example. So we're saying if you have money, if you have wealth, it has to generate some sort of income so as to grow, right? One of other critical issues also, which we are going to share, is that managing and protecting and sustaining your wealth is very critical. There are a lot of individuals who have made money. The first 2 stages, they've done it, right? They grew their empire, right? But in terms of managing correctly, protecting, and then making sure that it is well sustained across their lifetime, it was not happening. Why? You know, one good key example that we usually give our clients, it's a social example. I'll give it in vernacular. I want to use usually vernacular makes people realize how important things are. So the example says, munhu wese tikambomutarisa upenyu hwake, even tikamubvunza kuti yo hauna kumboita are musikana kana mukomana unoti ya apa ndanyatsokuona hangu munhu wangu chaiye kungoti hangu ndandisiri serious. Tomboti munhu ari kuchema-chema kuti hayi mwari asi kundipa zviri kuramba zvazodai zvazodai. Kazhinji tikatarisa munhu iye anenge ane paanotaura kuti hapa ndandisiri serious, but munhu ndiye ainyatsokuita. Meaning in across one's lifetime, we all get an opportunity. It can be social, like the example we have given, or it can be in terms of monetary. Kazhinji hakuna munhu unoti handina kumbonasa kumboita kanguva kandanga ndichimboita mari, right? So you find that opportunity always comes. The key issue, do you build and grow the cash flows when you are at the top? Do you manage and protect and sustain this wealth when you are at the top? Because at the end, you grow old, or that opportunity will come and go. Right now, there's an opportunity. It's illegal. We can say it, but it's an opportunity. People are making very good profits from trading currency, right, out there. But the same, if you look at what happens in 2008, when the economy stabilizes, they'll go again into poverty. It means they've not managed and protected their wealth when they were really raising or managing to generate a lot of money. Fourth, it is very important to hand over to the next generation. We'll explain some of the issues that are critical when handing over to the next generation. Right. So this is the slide where we are going to talk a bit deeper about these issues that we have said. Creating cash flow, normal work, employment, business, right? It can come, you know, some of the cash flow comes from returns from the current assets that you already have, right? So you might have your houses, right? Are they generating cash flow, right? That's very critical. Liquidity is king, right? When we say liquidity, imari cash, right? Or near cash, which means if you need to use it instantly or within the shortest period of time, you can use it, right? So to tap on my example of liquidity, if you look at it, I'll give an example that usually happens. I come from Mani Maruzeva, or I grew up in that place, right? Every time I go there, now and then you find a parent selling maybe a beast, a cattle, it can be something that they are selling to pay school fees, or they have a bereavement, right? So you find that a beast that should normally be priced at $300, because of the emergency, they are selling it at $150, $100, right? Because they have a problem. But because I don't have the $100 or $150 right now, I'm not liquid. I won't be able to take note or take a advantage of this underpriced asset that is there on the chip, right? So people who have liquidity are able to take advantage of cheap assets that come to the market. A good example is the Indian community, for example. They keep a lot of cash. So you then find that a lot of the buildings in Harare, right, unless those that are owned by big companies like Old Mutual, you find that that community owns those buildings, because when someone is selling that property and there's an emergence or a problem that they need to solve within the shortest period of time, they will tell them, I can offer you 50% of whatever you're saying you want, right? So because this person is under pressure, they will accept, right? So liquidity enables you to take advantage of assets that are coming to the market on the cheap, right? If you look at their sites like Property 24, in Bino is 200,000. One point is that after a month or so, you have 180. After a month or so, 150, 140. Because actually, kuna mbinga ine cash yakandomirira changa desperate chete. Then after some time you find yakazenda ne-120. It's because papane mbinga yangaine mari. So sometimes you can, if you are not liquid enough or generating cash flow, you are not able to take advantage. A good example is pataichema COVID worldwide. There were actually more billions created by the billionaires and some of the millionaires out of COVID, right? Because of the catastrophe and the problems that happened, a lot of people were selling their assets on the cheap, right? It's never lawyer because so they started selling whatever they had, right? And what it means is that munangane cash flow took advantage, right? Right, Microsoft, you talk of the big companies, Apple, their share prices went very, very down, 50% down. So someone with liquidity took advantage. Liquidity is very critical. My investment. I think this is not a problem to your businesses or your profile as doctors, because you fairly get a lot of cash flow coming in. I think the problem which I found maybe in professionals of our caliber is that the net cash flow is usually zero. What comes in goes out, right? Vamwe vanoti vakaita mari yowandaziya vanorora mukadzi wechi2, wechi3, wechi4, right? Kututsira my expenses, saka income iri kututsira but even the expenses are also equally eating into the money, right? So cash flow net of income minus expenses is not growing. So that is very critical. There's what we call lifestyle inflation, right? So you then find that as your fuel consumption is equally increasing, your car maintenance is equally increasing. If you are not careful, motor expenses were taking 10% of your money when you are still poor. But when you are now rich, you are even allocating 20% of your money to motor expenses. So in net terms, you have not really done anything. So that's very critical. Let's always remember that. Then, create a cash flow through net cash flow. We need to cook the money, right? There is a difference between saving and investing. So with my friends, we have a certain group where my classmates coming way back. So someone say umwe akati atida kuita stock mukanda. So we were very open to say, they were doing mukanda, they were saving, there was no earning there, right? So are we saying we can't just save on our own, right? If we can't save on our own, then let's do stock. But right? But investing, we are investing in an asset that will generate an extra dollar. When you are saving this $50 panopera 6 months, 600, you have not earned anything. So unless you are saying you can't save, yes, do mukan, right? Or keep money in the bank just to be disciplined. But investing means you have to invest into something that is going to generate money, right? This can be properties. You can buy properties, rent, income, grow the wealth, right? You can buy shares. I will explain what shares. My shares are magic, and I know one has trust, but I will explain how it's very simple to understand. Let's say I want to start a company that requires $20 today, or let's say $100, right? So if you want to do a company that requires $100, and we are 50 people here, we say bring $2 each, right? Then we have $100. So back then, instead of chinoratidza kuti ane portion mukambani tikati ngatichigadzira 50 mashares rimwe riri worth $2 zvinoratidza kuti une $2 yako pakambani iri worth $100, right? Yatagadzira, right? So kambani yayo tanga kushanda panopera gore maybe ane $200 tikatarisa isusu tichindone 50 shares dzedu dzedze. So one share tikati $200 divided by 50 is now $4. Kutaura kuti share rimwe riya bepa riya ratakapanana pakutanga worth $4, right? So that's how shares grow in value. As the company is growing, the value of your portion in the company is increasing. So shares don't go back to what you have a proportion, you have a portion of ownership in this company. But so can about zvinozonetsa pamberi apo vamwe vanoda kutengesa vaita matambudziko, right? Vamwe vanenge vasikaita kuti nezvebusiness racho pakutengeserana paya munogona kuti ngatitengeserane pachedu, but zvinonetsa futi, right? Because ngatimboita kamusika wemashares akuti puro anongouyawo with his shares and says I want to sell to Samson, right? Samson wants to buy. So then this is to share $4, but Samson, because Anofara company might be willing to buy it $5, so I can actually make $3 profit. But Samson equally can argue that I know $4 is not $4, it's $3. So that's how we end up with something called the stock exchange, right? So in essential, what we're trying to do is to say, let's enable people to buy shares in various companies that are available. We in Zimbabwe Stock Exchange, right? My shares are not going to kutotenga Zimbabwean dollars, US, right? Unless you want also to participate in shares, say Johannesburg Stock Exchange or New York Stock Exchange, that requires the Forex, right? And these companies, if you go, for example, there's a company called Simbisa, right? It owns Wana Bakers, Nana Chicken, go to their stores. People are buying in US dollars. That company is growing like big time. It has shops in DRC. It has shops in Ghana. It has shops in Mauritius, almost 12 countries in Africa. So they're earning a lot of Forex. If you are also owning a share in there, it is also growing accordingly, right? Last year, in terms of shares, Zimbabwe Stock Exchange, kana wanga wakaisa dhora rako rema-US, wori converta kuendesa kumabond, right? First, anditikaroita maybe $100, anditika wotenga mashares. On average, you should have made at least pakapera gore mabondi ako anga arimo kana ma-RTGS, value ema-shares was worth at least going to be kaitivana ne-parallel rate, waigona kutoona kuti $3. So imagine my doctors mnemari 5,000 could have been tripled to 15,000 last year. These 2 months only, the past 2 months only, people have made over 20% in real return. When we say real return, to put it in US dollar terms. So right now as we speak, by just spinning Zimbabwean dollars, by buying shares, right? We'll explain why we are having this big returns. So what we have actually found at our bank with friends also is that instead of buying USD each time we get RTGS and storing it at home, then you start eating into the money, the best is to buy in shares, right? Most have the advantage. A silly example which I'm going to give. Kala one ma US mumba anozikana ndi baba kana madam aripo andoda kumborukwa afazodai pane kapati ketindo kumboshika ndokupirawo $50 wotoapa yakutanga urida mari yayi handiti. But kana one mashares kuti madam ozati mashares andokona iweekend pendichazoatengesa Monday but yatodarika watosevhe mari. Right. So you find that you also get more disciplined in some of these assets than keeping cash. Right. There are things like pooled funds. If you look in Zimbabwe right now, people are building my garden flats or my cluster homes. These are people who are sometimes combining. Right. I know of some 5 guys. One is a lawyer, one is an architect, one is a banker. I've forgotten the other 2. So they've been contributing money.
Prosper, you have 10 minutes.
Not a dog. So they've been then adding their money and combining and making, they are buying the building, the cluster homes. So they've done about 5 cluster homes, like one stand of 2,000 square meters, they put about 10 cluster homes. So they have about 50 now. So they're now saying, look, let's say one remains with the other 10, one remains with the other 10. So you find that some of these investments that we do require a lot of money. You can combine together. Then you start investing, right? There are things like money markets, fixed deposits. Some people invest in art and collectibles. What is critical is always to seek advice. Don't invest in something that you don't understand, right? So always seek advice from bankers. You can look from brokers, the asset managers, people who have a bit of more knowledge into that. You might have friends, for example, as property. Ask people like property architects. They know what is happening. Quantity surveyors, real estate agents who know what is happening, so that you also don't buy assets on the high, right? What is critical? Want to make money. Think about yields as much as possible. When you talk about yields, we are saying return yako per dollar rawaisa ichanga yakawanda sei. Mukatarisa dzimba dzekuma low high density seichitumbiza, right? Inenge iri 35,000 in value. But because you are renting per room, you add your maybe 35 per room and so on. You might find that tikapanopera gore mari raised per dollar of investment compared to munhu ane imba ye 500,000 kuborrowed achichaja 1.5 pamwedzi. Ari kuita more profit per dollar of investment. They are kuchitumbisa. So you don't put emotions into some of these things. Always think when you are investing now, always think about what is the return that I'm getting, right? Then we have to protect and manage our assets. For example, for fire, for example. Right? So you can build all your assets for 60 years or 40 years of work, then you lose it when a fire happens. So insurance is critical. Just insure your fire, your property, or your whatever investment. It can be a car, for example. Make sure you insure. Also diversify. Diversify, we are saying, try and have a balanced portfolio where you have some shares, you have some properties, you might have some cash, so that if properties are not performing, there was a time when the rents were really low, right? You know your shares are sort of keeping some balance, right? Some people invest in one type of an asset. Usually, those people, they struggle when there's a downturn in that market. You can look for management from experts, your bankers, and so on. Spending policy is critical, right? If you say my expenses should be 20% of my income, always stick to that. Structure of investment vehicles is also critical. But people usually are normally taxed more than companies. So usually, for example, myself, I've started a small family investments vehicle, but it's more tax efficient, so to speak. That. So if we create a trust which says of the income that comes, we're going to share 10% each, right? Maybe there are 10 beneficiaries, or an uncle can add 2, and I'm going to share 50-50 of the income. Havagoni kutengesa that trust at any moment in time. So you are protecting them from eating the money more than what they should do. Also, a good example is that baba, mama wakafa, right? Kana my investments enyanga ari mutrust haagoni kutorwa nesmall next year small house ichauya kana slay queen rinova richida kudya wealth iyoyo. So you are even protecting your wealth from yourself, right? So trust can be helpful. We've talked about partnerships. You combine, then you invest, right? Also think about tax planning. People have been usually then vanozoona at retirement or when vakafa kuti kune inheritance tax yobva yadya a huge portion of your wealth. Things like trust are not taxed. So kune ma-benefits anenge ariko ikoko. Business succession planning, right? Vana vachazoteka over here, or muchazoisa ma-professionals, maybe in your space where you are owning practices. Zvinhu zvinofana kudiscusswa pachine nguva other than munhu azodi azofa. Family education and communication is critical. Vana ngavadzidziswe zvatiri kutaura izvi kana maakutozviita vana ngavadzidzisewo, because kazhinji pamunozofa the wealth goes with you, right? So that's what we also mean nature human capital. Try and train your children or whoever is involved in your life so that after you are gone, they can continue to manage and continue to build and grow the wealth after you are done. With that, that's what we wanted to try and share, to say, how can we build better wealth management when we are still making a good income in order to protect ourselves when maybe the income is gone. Thank you very much, Doctor.
Thank you so much for the nice presentation, Mr. Mateas. I really would like to acknowledge this kind of presentation, really refreshing out of our usual corners that we normally understand. The aspect of wealth creation and management is probably something that doctors are not very good with. They just want to make sure the patient is healthy. That's all they know. So when you bring this type of presentation for us, we really appreciate it, and I hope that this will make us better people in terms of managing our assets, our finances, and our health. I'm going to open the floor to any questions for the last presentation. Any contributions or any questions? Okay, there's a question from Dr. Masimba. He says, what are your views on Bitcoins? Please, would you like to respond to that, Prosper?
Thank you very much, Doc. With Bitcoins, it's an asset that is still coming up, right? And people have made money from Bitcoin, but it's an asset that is not backed by anything, right? In any way. If we are buying, say, shares Econet, ma booster acho tinoaona, airtime iri kutengwa tinoiona, Bitcoin does not have that underlying enterprise in between. So increase in price yayo iri based on maybe emotions, right? Kwanza uneona kuiraki Ukraine yakadonha. So you then find that its returns are not based on real economic fundamentals, right? So unless you are betting Maria Doro, $5, not a big portion of your wealth, I would not recommend Bitcoin, right? Or you have to invest in the short term. You get in, you get out, like what we call speculation, right? It's not an asset that you can really say, I'm going to build long-term with it. Tinevanhu vakatenga Bitcoin ripa 65,000 per Bitcoin. Ikadona to 30,000, they've lost 50% of their wealth. And there was belief that Bitcoin is like gold. where it does well when there's inflation or there's war or people are facing challenges. It has turned out that Bitcoin is not that safe investment in terms of sort of stabilizing your portfolio or your investments. So I think small portions of your wealth, if you want to speculate, definitely yes. But to build a long-term program or investment horizon, I would say no. I think there are a lot of reasons that I can share, but I think for the sake of time, you can always then come and discuss. I think Dr. Nyakura can even share my mobile. We can discuss further into some of the pros and cons of Bitcoin. Thank you.
Thank you so much, Prosper, for the nice presentation and the response. Dr. Rambana Pasi says, thanks so much for this financial segment. Can we have it all the time? So perhaps, Prosper, you can organize with your colleagues so that once a while we bring you up on our presentations and you give us more information on how to protect our wealth.
Definitely, Doc. I think it's perfectly fine. We can even then say one day we are talking about insurance and how it can work for you. Next time we're talking about how to set trust. Then we can have a series of engagements where we go deep into each and every aspect of investment.
Excellent. Thank you so much. Are there any other questions to Prosper? It looks like the people have understood and should be able to communicate with you even in your inbox, and if they get more clarifications on any issues to do with their financial management. Thank you so much, Prosper, and we really appreciate you taking your time to present this to us.
You are welcome. Thank you very much.
All right. So this brings to an end to our presentations for the afternoon and our presentations for the day, which started in the morning, and there were the mid-afternoon presentations and the late afternoon presentations as well. We really want to appreciate all our presenters. And before I hand over to the president, is there anyone with any questions for any of the presenters from the morning to this time? Please show by a raise of hands or by a comment in the chat box. I don't see any comments at the moment. I would like to ask if there are any housekeeping issues to be brought up to the team before we hand over to our president. Any housekeeping issues? All right, it appears there are none. So I'm going to hand over to Dr. Magure to give us the closing remarks for the day. Dr. Magure, over to you. Dr. Magure, over to you. Or if there's anyone else who had been designated to give us the closing remarks. I see Dr. Magure is on the team, but maybe you need to unmute yourself before you give us the closing remarks.
Thank you, Dr. Nyakura. While we're waiting for Madam President, I just want to take this opportunity to thank you so much for facilitating this last segment. We would like to thank our guests, Mr. Meteshe. We so appreciate that presentation. I would also like to take this time to thank each and every session chair. We are so grateful for the way that you conducted. It was a very insightful scientific session. Thank you to each and every one of our presenters, and particularly to our keynote speakers. I see Dr. Moava is back on, Prof. Chauke. Very, very interesting insights on the analog of the Bin Laden mission. Dr. Moava, that was very insightful. And Prof. Chauke, thank you for taking us back to ensuring that the environment is healthy for our babies. And we want to say thank you to all of our sponsors. New Avakash, want to thank the Fetal Medicine Foundation and each and every presenter. Thank you to the subcommittee chairs for working so hard behind the scenes to ensure that we had presentations on time. And so I would like to call upon Dr. Moyo. Dr. Moyo, is there something you want to say briefly around scientific meetings in the next quarter, in the next months, what people should be looking forward to before we close?
Thank you very much, Dr. Maposa. In brief, what we're hoping to achieve in the next quarter is a physical meeting. If you look at our attendance from the morning, we're around 80, now we're down to 40. So I think it's very difficult for people to spend the whole day looking at a computer. If the pandemic allows us, we're hoping that our next meeting will be a physical one. I've just seen the surgeons they had a physical meeting. We'll try and learn from them how they did it, but in the next meeting will be a physical one. I think that's all I can say.
All right, thank you very much, Doc. So colleagues will be looking forward to seeing you at physical meetings in the upcoming months, and of course you will be getting updates. I would like to call upon you in terms of just ZSOG. We would like to encourage each and every one of us to please pay up our subscriptions early. I know that we usually do it towards the end of the year, but it would really be useful for us to be able to run with some of the activities that the various subcommittees have planned for if we do pay up those subscriptions early. And just to highlight on what some of those activities are, we have been working on a strategic plan. We had a strategic planning meeting, and in the next few weeks, with your indulgence, we will be asking for a meeting where we can share a draft of that strategic plan so that you can input and we can finalize and we can hold each other accountable to the activities that we would like to carry out. So that is something that we're excited about, that we'll be looking forward to. The PR subcommittee has exciting activities coming up, and they've already sent a flyer to begin to commemorate some of the health months and the health days. I think March is endometriosis month. You may already have seen that flyer. Please tag it on your social media and send to the various groups. We also have some exciting things that are going to happen in the social arena, because we know that we need to be healthy, spirit, soul, and body. And so we have some things that are lined up for that, and I would like to encourage us all to participate in doing that, and again to ask that we try and pay up our subscriptions on time. So in the next few weeks, we'll be asking for your time, maybe an hour and a half tops, just to be able to present that draft. And so at this point in time, without much ado, I would like to try again. Madam President, is there anything that you would like to say before we close off the meeting officially?
Hi, Dr. Makosa, thanks. I have nothing else to add. Thank you.
All right. Thank you, Madam President. So we would like to thank the Lord for watching over us and seeing us through, and for great network most of the time. Again, thank you for everybody who participated. Let's meet again the next time. Have a blessed and fruitful weekend and spend some time with your families. Thank you.